evening. Dr. Changaris is near and dear to my heart. I'll start by saying he was a big part of my training when I was going through my pre-doc and post-doc residency in the hospital. And he's really been an advocate of an integrated approach to health and wellness throughout the hospital. Pain management in particular has been a passion of his for quite some time. Dr. Changaris, I will we'll just say one more thing real quickly. For those of you who are new here, Dr. Bramson, who's on as well, and myself, co-founded this organization, Northern California Mindfulness Institute, which is really meant to bring people together across disciplines to learn from each other, to support each other, to network together. And it's been an ever-growing community that we're really proud to be a part of. And we're certainly honored to have each of you here today. Dr. Changaris, I'm sure there are 1,000 things you're involved with that I probably didn't mention. And so maybe you can speak to a little bit more about who you are and what you do, and then kick us off.
Thanks, Dr. Wilson. I think, you know, in a certain way, credentials are kind of meaningless. And what we really do is drop those credentials and engage in a space with people at a profound heart-to-heart level. And we're going to be talking about pain tonight. And one of the deep things about pain is that it pushes us into profound existential spaces of what it means to be human, what it means to be alive, what dignity is, what values are. And so maybe beyond credentials, I just would say that I'm really somebody who is a deep advocate for engaged living and engaged learning. And I'm grateful to get to be with you all in this process. Barbara and I are both fellows who are part of the UCSF Health Force Fellowship, and that's one of the things is that I'm involved in. I've been leading some of our opiate pain management collaborative in Contra Costa County for 7-ish years. We've developed 4 integrated pain management clinics that have physical therapy, medical doctors, and psychologists together, and we've published work a little bit at some conferences on it, and we've been able to reduce in the last cohort that I looked at our opiate levels from about by 45%, which is, and while pain management was stable or improved, and suicidality dropped and depression dropped.
Wow.
Because we have 3 big epidemics here with the opiate epidemic, and one of them is that chronic pain is huge, and it's out there, and it needs a real treatment. The other big one is that opiates and pain lead to high suicide rates, the combination of which lowered the life expectancy in the country itself. And then the third big epidemic is the epidemic of addiction in the aftermath of opiates. And just to give a flavor for how deep opiates are, if you've ever been a child, and I'm assuming that nobody here has, and fallen and skinned your knees, your brain has inside of it an endogenous opioid system that's grown by the parental or the caretaker love when you're in that crying space. So the swoop that your parent does, the sitting with you, grows the endogenous opioid system. So more than any other medicine, when you remove it for people who face trauma, for faced overwhelm, it's like you're removing love itself. So what we have to find ways is to dignify the process of pain, to pull out some of the way that bigotry and oppression impact people with addiction, and help find ways to help people build connection and wholeness while living in this process. Now, I know we're in the middle of a massive pandemic of COVID-19, which is pushing people to be in isolation. And as Gabor Mate said so beautifully, addiction is fundamentally an illness of being alone and being disconnected.
Yeah.
So we're on the edge of another wave of mental health problems, of trauma. And I think that if we take this seriously as healthcare providers, we can really amplify the ability for communities to heal and to treat the folks that we serve. The other thing that I want to name is that we are also in what the APA called an epidemic of racism. And I want to make sure that I say that those are light words, and that the amount of suffering that we're seeing on a grand scale come to the forefront is not representative of a new thing, but something that's been there for years. And the interaction of the opiate epidemic and systemic racism is profound. And we'll talk a little bit about that today, although it's not the direct topic for us. But I would be shocked if it's not on everybody's hearts. Everybody that I've talked with has had what I would call a profound realization of our responsibility to be each other's keeper, to make this world a safer place for all bodies, for all spirits and all minds, even if it makes us uncomfortable as we do that deep and difficult work together. So I'm grateful to share the learning space with you all. I have a lot of information. I'm not attached to my slides, but I do have a process. Could we maybe just open up by everybody just saying their name and one thing that interests you in pain practice? And if that's a problem because of like mute functions, I'm sorry, Hunter. I don't know.
Yeah. Well, I'm just curious about actually some of the things that are trending right now regarding the multiple crises we're facing, both the pandemic, the Black Lives Matter movement, how opioids affects the population differently, how we might approach the problem differently depending on which demographics we're dealing with, what's universal about it, and just what you see in terms of the most current effective treatments, that you're aware of to make an impact. Just one question. That's it.
Absolutely. It's just the small stuff, just all those are just like perfect. Thank you. We actually will get to a lot of that. For better or for worse, my personality style is to know a domain all the way through. I can't tolerate to not, so I tend to start off from a global picture and then move in. So thank you for that. We'll talk about that.
I'm Jim Bramson, and Josh already introduced me, so
absolutely.
Nice we know each other. So.
Yes, we do. Thank you for being here. I don't know if Barbara, you want to introduce yourself? I'm sorry for my unabashed affection.
I'm Barbara Ackerman. I'm with the Riverside University Health System, and I'm the Assistant Program Director for the Family Medicine Residency Program. And one of the things that I did in the residency program was start a group visit for patients with chronic non-cancer pain who were using opioids, and I was teaching them a variety of skills, many from Marsha Linehan's DBT skills training program. So emotion regulation and distress tolerance was part of the whole package, with the relaxation breathing and the guided imagery and so on and so forth. And I'm here tonight because I really want to learn more about the neurobiology that Michael is an expert in.
Thank you, Barbara.
I'll introduce myself real quick. So I'm Josh Wilson. I've got a private practice in Orinda, co-founder of NCMI with Dr. Bramson. The topics that are of interest to me, one you already touched on, Dr. Changaris, is the kind of relation between adverse childhood experiences and chronic pain over time, and also other health outcomes, if we get to that at all. Certainly, I'll echo what Barbara said around just the neurobiology of chronic pain is something that I'm very interested in learning, and also non-pharmaceutical interventions. And I'm really curious about the efficacy of different interventions so that I know kind of where to prioritize kind of the first point of intervention with certain people, as well as what I think a lot of this is about is what the right patient-centered approach is, an integrative kind of combination of disciplines to support positive health outcomes.
Thanks, Dr. Wilson or Josh. I don't know, Saul, would you feel comfortable introducing yourself, or who's next?
Sal, if you're going to introduce, just make sure you take yourself off mute while you do it, please.
I can do it too. Oh, there you go.
Hunter did it for you. Thank you.
There you go. Okay. Okay. So I'm in private practice in Seattle. I'm interested, two cases that I have, one especially is driving me a bit bats, and I thought that hanging out with you guys, I might pick up a few things that will be helpful in treatment. Beyond that, I've been studying. I wish I had studied harder, but I've been studying with Alan Shore for the past 15 years and started the Seattle group.
That's how we know each other. Yeah, okay.
That's how we know each other. That's probably how we cross paths. But so I'm really looking forward to hearing what you have to say about the neurobiology of it, which I wish I knew more, but I don't.
Yeah, we're good. And I'm a Shorean by root, so for sure you'll hear echoes of him tonight. Thank you, Sal. Is it Svita? Can't quite hear you. You're not off mute. But
Yeah. Yes. Hi. Hi. My name is Sveta.
Sorry.
I'm working currently with foster youth and families who are going through addiction. So a lot of CPS involvement. I also have private practice in Berkeley and in Lafayette. What I'm curious is about the impact of trauma and the addiction, and also the impact of that on children, and everything else that everybody has said so far.
And it really has. I think we haven't begun to see the long-term impacts of the opiate epidemic because of the way addiction ruptures the family system.
Yes.
And our inadequate support for families around addiction makes it hard for the recovery and has a deep impact on how a child develops. So it's an important topic.
Right. And I mean, with the whole process, also the child being removed from a parent who is, experiencing substance use or abuse. And again, how is that also impacting attachment and different areas of the child's life?
Well said. And there is actually an entire also body of knowledge on children and opiates. This is not focused on that per se, but if that's an area of personal interest, because sometimes children, many times, pain will be managed in the same way in youth. I'm happy to put you in the right direction for those resources.
I appreciate it. Thank you.
And Hunter, did you want to? I know you're here as our tech guru.
Sure. No, I'm happy to share. So my name is Hunter Romano. I am actually in my last week of classes at the Wright Institute. I'm a third-year student. Yay! I know. I'm really excited. I am moving onwards to the Richmond area multicultural services internship next year. And I think this is just a very important topic in general. I worked at an inpatient hospital this year, and in addition to severe mental illness, I saw so many substance use issues within the client population there. And so I think this is really important. And it'll be the case that I'll be working with a lot of underserved and substance use clients next year as well. So I think this is vital information for me as a growing professional, and it will be essential to my work. Last comment though, if you haven't sent your email to me, or if you're interested in sending it to me, you can add it into the chat box. Thanks.
Oh, I did put it in the chat box. The Google
great. Thank you.
And I'll encourage everybody to go over to the chat box and click on the Google Drive, because there'll be some resources that I'll want to pull to. One of them is an overview of pain education management that you can use with patients. That has everything from like, what is a TENS, how does it work, what's the current NIH response on acupuncture, how it works, to what is buprenorphine and other kind of more concrete things. And then there's, in the back of that thing, there's also some tools that I use as patient education with an image, and then some education points.
Sorry to interrupt you, Michael, but we also have Teresa. Were you able to see her?
Oh my goodness, no, thank you. I'm so sorry. Teresa, would you be willing to check in, and I feel sorry for being rude. Thank you for being here.
Oh, no problem. Thank you. Yeah, I'm a chiropractor. I practice functional medicine for about 20 years now, and my curiosity, besides everything that everyone else said, was how do you dialogue with a patient that you are trying to wean off of opioids? I'd like to know more about that.
We will actually do some real practice in that, and that is, there's a needle to thread there, you know, and I'm really grateful you mentioned it. And one of the framings that I have is that if you want to have the biggest predictor of outcome with chronic pain, the biggest thing is called pain catastrophization. And what I see is the biggest clinical factor for positive impact for both pain and less likelihood of opiate addiction is what I would call reducing the medicalized belief in pain management and expanding people's cognitions about what is possible. And so a lot of times people will come in believing that the opiates are the only solution, and having that difficult conversation to get them the new science and the new understanding about how pain really works really amplifies our capacity so that they don't end up believing the medicines are the only route. And we'll talk in more detail. I have a lot of practice on that. I believe we met at the last NCMI event that I was at, and I just wanted to say I really enjoyed that conversation. It was memorable. If it is you, I can't see your face to know for sure.
Yes, we did meet. Thank you. I feel the same way.
Good. So I'm going to go ahead and launch in, and just for an interpersonal guide, I don't lack for how we manage our time. I don't lack for things to say and information, but I also value input and dialogue. Don't hesitate to just speak up or unmute yourself or ask questions or share an insight. I have enough of an overview that I can make sure that we get all the core topics, but still have a good conversation. So one of the things I just want to say is that oftentimes with health issues, we try to pretend as psychologists that life stops at the neck and that health issues don't matter. Sometimes I'll open up my health psychology groups with, you wonder why a psychologist is running a group in a medical setting, and it's because I believe the neck exists. Some medical systems are still looking for it, but we found it. And the truth about this is that if you have a patient who has diabetes, it's going to impact their depression and their anxiety in a bidirectional manner. And pain will do the same thing. So if you think that 1 in 10 Americans have chronic pain, and more people with chronic pain have concomitant mental health conditions, both as an antecedent and as something that's caused by the pain itself, you just know that there are more people on people's caseloads with pain than they're asking about. And if you're trying to fight depression when someone can't take a walk, it's much, much harder work. And psychologists oftentimes know that pain has a psychological component, but don't really know their role well enough to know how to engage. And then oftentimes we have other providers like our amazing chiropractor who know this huge other body of knowledge, but we don't dialogue well enough to create a coordinated plan of care. And what I'm going to say, and this is what the evidentiary guidelines say, this is what the CDC says, it's what the NIH says, it's what the WHO says, and despite all of the anti-science, anti-WHO stuff that's out there in the world these days, they are really a good science source. Integrated management is the standard of care for pain care, and it almost never happens. If you want to know the driver on it and why I'm talking about this, is that once the opiate epidemic, once you realize that we can't just treat everybody by giving them a pill, so therefore what? What do we do? And so that's my big question to us, is can we take this as something that we live forward in our practice and wrestle with, like Sal was saying, the way that these cases can feel so complicated and heavy and dense and frustrating at times. And part of what led me to be interested in this is that it kills people. And I've seen patients of mine die from this. And I wanted to find a way to stop it. You know, sometimes we can look and say, no more, not on my watch, let's stop it. And I haven't been able to stop it, but we've been able to have a meaningful impact with this. I know we've had, as of the last time I checked, we had a 17% reduction of overall opiate prescriptions in Contra Costa County overall. So that's more people alive. So let me talk a little about what this talk is focused on and what it is not. Here are the components of pain management. You have what need to have better pain care overall and manage the opiate crisis. We need better data. I'm not going to be talking about data science tonight. We need more addiction and prevention and treatment and recovery services. We will touch on it, but that's not going to be the main focus. We also need more overdose reversers. If you have, I would say it is reasonable for all households to, if anybody has ever taken Vicodin, to have something like a naloxone in the home. The person who trained me on how to do the naloxone nasal spray saved a life on the way to training me. She stopped her car and saved somebody's life. We had people die in the parking lot of our hospital, not able to make it in because we didn't have enough naloxone to rescue or reverse. And if anybody doesn't know what it is, naloxone is a highly selective mu opioid antagonist. And this may sound like gobbledygook. It is not. I will make sure by the end of the day we have it down. Mu is the opioid receptor. It's a neurotransmitter like serotonin. And an antagonist will kick out the heroin or the other drugs in that receptor slot and save somebody's life. If anybody saw Pulp Fiction, if I'm going to date myself, the stab to the needle to the chest, that's an older version of using that. We need more of that, but that's not what we're focusing on today. And we need better research, and that's not what we're focusing on today. But what we are focusing on today is better pain treatment. Because if you stop that, what many times you can stop is the escalating doses of pain medicine. Just this week, I had a nice talk with a patient who has tremendous chronic pain, wants her doctor to prescribe an opiate, but she's 28. And there is nobody who's 28 that in 10 years will not be on triple the dose. And is triple the dose sustainable or livable? And so just had the difficult, hard conversation about how do we bring in other pain management things and make a strategy so that this doesn't become a life sentence or worse, a death sentence. So here's the goal today. I want us to move from the idea of a hammer to a toolkit. One of the proverbs from the maintenance crew from the summer camp that I worked on when I was a teenager, they would always joke that if it can't be fixed with a hammer, it's going to be beyond repair very soon. You can hit it as hard as you want, and well, the window's broke. Can't fix it now. And a lot of times that's what we have is we have the hammer, which is an opiate med. And let's move from that to a toolkit that can meet somebody in the nuanced way of what it means to be a human being, to have these deep, heartfelt, and often ethical conversations about how to manage pain and have a meaningful life. Maybe the biggest thing that I could say to you as we talk about this today is that you are going to have pain, and I am going to have pain. And I am going to have suffering behind my pain too. To poke a little hole in some of our mindfulness experts, suffering is going to be there too. But how we respond to that suffering and how we respond to the pain, that oftentimes makes the difference between a meaningful life and an unmeaningful life. And one of the deep things that opiates do is they rob people of the interest of engaging in developing a meaningful life. If you take a little mama mouse and you give her a tiny mouse dose of opiates, she will stop licking her young. Because that stress that happens when she sees the distress of her infant doesn't happen. She feels the numbing, soothing effects of the opiate and stops reaching out. So it fundamentally impacts the attachment process. And that means that someone can be on their couch, disengaged from life without that intrinsic motivator to move forward to wholeness, to connection, to vitality, to entry into this brave, wondrous, and often heartbreaking dance of constructing a life that really matters, you know? And on a concrete level, I'm going to hope that we move beyond a Cartesian model of pain to understanding the brain's role in neuroplasticity. The biggest metaphor that I want you to get today is that chronic pain is an overactive threat and defensive response system. I'm going to say that again. Chronic pain is an overactive threat response system. So if I were to say to you that the only treatment for an anxiety patient, for a patient with anxiety, is a benzodiazepine, because that's the only thing that can affect the physiology of pain, you would tell me that that was laughable. And in the same way that anxiety can get generalized and expanded and lead to overwhelm, pain can do the same thing. We'll learn a little bit about how pain goes through this neuroplastic process today, and we'll learn some metaphors to talk to your patient about it. The biggest metaphor that I'll say is that pain is not like you have a light switch with a wire that turns on a light, because our brains aren't wired like that. They're more plastic. What happens is like the light switch suddenly gets connected to the alarm bell because of how pain works. Pain's a highly salient neurological indicator that the brain wants to learn because it seems really important. In the same way, anxiety is a highly salient neurological event that people can learn. And in the same way you can learn pain and learn anxiety, you can unlearn anxiety. And so there is a neurological process of doing that. And we're going to talk about some of the things that make that more possible. And then the biggest thing is I want to give you, first of all, a map, because if you have a map, who cares what intervention you use? That will have to do with your power, your strength, your personal clinical voice, whatever moment arises between you and a patient. And the Y model is going to be our basic map for how you kind of anchor these things, and a bit of an overview of chronic pain management. Anybody have any questions or comments or worries or concerns or things as we're talking now?
I just imagine you'll probably get into pain gate theory and things like that during the talk. Wonderful. Thank you.
Yeah. And so the first thing that I want to do is I want us to get a sense of how malleable our nervous system is. So I'm going to show you a YouTube video. This on the right-hand side is the scientific version of what I'm going to show you as a carnival act. The carnival act is a little bit more dramatic than science often is, and has a little bit more punchiness to it. This is in the same way we've probably heard of a phantom limb syndrome. This is how the brain learns pain. From a mindfulness perspective, I'd like to give you a frame using monkeys. There are researchers in Japan that noticed that monkeys don't have the same ability that I do with this pen. If I take this pen, I can incorporate it in my body map so much that I can reach out and touch the pen lightly or heavily as if this is a part of my own body. Or there's an old quote from Japanese brushstroke art that says, you want to paint so passionately that if the brush were cut, it would bleed. It becomes literally a part of who we are. Now this does happen for our primate relatives, but it doesn't happen for macaque monkeys. So this Japanese researcher trained a group of monkeys to incorporate a broom and sweeping into their body map so they could do it. And it took 12 weeks of steady learning and training, and he couldn't get it any faster to get that monkey to get this whole neurological process that other monkeys don't develop in the wild. Why I think that's an important metaphor is pain can oftentimes start off as acute, an occurrence of pain, and then the brain begins to develop this neuroplastic process that creates what feels like a cement pathway for it, but it isn't. It's much more alive than that. And I'd like us to get that practice to be able to communicate about that. And this is called the rubber hand experiment, where the researcher, well, I'll let it speak for itself rather than me lose the drama of it. And this actually has led to some real therapeutics. This is just a BBC fun version of it. I've just been informed that you can only see slides. So sorry, everybody. Getting my presenter stuff together here. We can see it now?
I see a white.
How How about now? Is it visible now?
Yes, it is.
Quite accurate. One, you can do that. We have whole devices out there that help people see with their tongues. If you've never looked it up, it's really worth doing. Our brain likes regular, orderly input, and if it gets regularly orderly input from any sensory modality, it will change. Maybe that's what therapy does too, you know. And we'll look later, and you'll see people with chronic pain will have a reorganization of their somatosensory map, of their limbic and emotional structures that relate to that somatosensory map, and to regulatory processes. And some of what we're doing in pain management is developing new tools to build and rebuild a more effective sensorimotory map that doesn't include as much of the pain. Anybody have any thoughts or questions or comments or? Okay. So this is the pain gate theory. Can you raise your hand if you've heard this one before? Okay, Barbara knows it. Dr. Wilson knows it. Good. I'm really glad a few of us know it. I oftentimes do this with chronic pain patients who've been on opiates for more than a decade and have been on an escalating dose. And I say, have you ever heard of the pain gate theory? And they say no. And then I ask them if they understand any of the principles, because maybe they just didn't hear the name. And they'll say no to that too. So the doctors feel overwhelmed. They're chasing the overwhelm with an opiate, and they've neglected one of the core parts about how pain management works. One of my phrases that I'll often give patients is, this is a theory like gravity is a theory. It was first proposed in the 1950s. And at this point, the accumulation of data has only confirmed it. We're going to talk about this in enough detail that hopefully it makes a little sense. And we can feel free to ask questions to get a picture of it. So the big thing that I want to say from the pain gate theory, the major take-home message from this is two things. One of them is that we have a descending inhibitory neuron that turns off or closes pain from the reception of the neurons into the brain. In other words, from our brain stem, we have something that tells our spinal cord, we don't need as much pain information as we got before. The part of the brain that does that is called your periacrial ductal gray, or PAG, as it's usually listed in the literature. You will know the PAG because it is what the amygdala impacts to make your heart rate go up. So to say that in clear sense, anything that affects the regulation of stress will regulate the ability of that neuron to impact the regulation of pain. And this makes sense. If I'm in threat, that threat from a stressor would make my brain want to see more pain, because threat and physical pain often go together. As I learned when I was bullied as a teenager, or as a child, not a teenager actually, I'm gonna get you had a pain on the other side of it, and the fear and the pain were tied. The fear and the pain are tied with a fall. The fear and the pain are tied with a surgery. So if you're looking for the connection between pain and trauma, it's right in the fundamental aspects of how pain gate theory works. And so anything that will close the gate of pain anything that makes you feel good, powerful, strong, competent, effective. If I have the belief that I'm a broken person because of my pain, which oftentimes people with chronic pain will have, people with addiction will have, I'm a broken person, that belief will close the gate of pain. If I have a belief, we'll open the pain gate, so it's easier for more pain. If I have a belief that pain is damaging my body, that the pain is a signal that, like putting my hand on the stove, that I'm damaging myself, that belief itself will make me open the gate of pain, because my brain will want more of it. And you can see that in this picture here. The attenuated symptom, this inhibitor neuron, this eye, comes down and turns off the pain, turning off the red nociceptive neurons. There's one more big part about this picture that's really important to get. And that's that we have 4 classes of sensory neurons. I promise I won't be this detailed, but this one is kind of helpful to get. 2 of those classes get what's called pain and temperature, and those are your nociception neurons. And the other 2 get deep pressure and touch. A few other things, but they're like that. If you've ever had a child with autism wear a weighted jacket, what they're doing is they're using the pain gate theory to override the child's stress system through the proprioceptive input. It's using the same map and the same model. The deep pressure hugs are the same kind of thing. If you've ever had a patient tap, it is doing the same thing for anxiety, working on the exact same system. And the way it works is this, is that your nociceptive fibers are thin and unmyelinated. Thin and unmyelinated. And what thin and unmyelinated means is it means a slow neurological signal. And that's because they're evolutionarily older. The touch and deep pain receptors are fat and covered with myelin, which means that they're going to be supercharged. They're like a fast track highway, whereas the pain signal is like the slow lane. And so this is why distraction works from both emotional and physical pain. Because if I'm 100%, in Linehan's words, unmindful of my pain, and 100% mindful of another event, in other words, I'm putting other sensory experience that is more intense over the pain sensory experience. And you all know this from like hitting your thumb with a hammer. If you hit your thumb with a hammer, the first thing you do is you say, ouch, or maybe not ouch. Maybe it's another word altogether. The cartoon bubble with like the X's in it and after you say ouch, and globally what that feels like is that pain has just gone everywhere in the body and your brain hasn't localized it yet. And as your brain localizes, it'll start to shake your hand. But if you've broken your thumb with a hammer, that would be a bad evolutionary idea. The reason we shake our thumb is because it provides pain relief. It's a reinforcer. Not that it's smart, frankly, because probably it isn't, although most of the time you just hurt it slightly, but because it provides an override to the signal of pain, dampening that signal and allowing that signal to relax. And so we can help people get these distraction abilities that will both turn down the pain gate and then override the neurological signals. To make this clinically appropriate, I was working with this woman for a while, and she had some pain, and her dad did too, and she was doing one of those kind of like sandwich generation things of caring for her kids while she cares for her dad, who had pain but was also aging and having early mild cognitive impairment. And she said, my dad would spend a lot of his days kind of nearly either subduing a howl or having a howl. But if you turned on a baseball game, for that entire baseball game, you would almost see a smile on the guy's face. His love for the baseball distracted him enough that it pulled his brain out of the pain cycle. And so this is one of the biggest things that we can know with pain, is that if you build a life of meaning and purpose in ACT terms, you start to reduce the amount of life that your pain takes up. And so sometimes I will sit with people around this big question, the ACT question. What are you willing to endure to have a life that matters to you? Are you willing to have a pain in the ass that really throbs sometimes, right? Are you willing to have to make friends with that? Are you willing to feel angry at your pain but keep moving, right? These are the deep questions. And if I say it as a psychologist sitting on a hill looking down on somebody, that comment and those questions will be received as an aggression. But if you can find a way to enter with someone to experience and ask them out of deep respect for the power of their humanity, then they can do something worthy, which is find something that's meaningful to endure this life. And so I'm careful about being flip. I'm a meditator. It is not unusual for me to sit on my knees for 10, 12 hours in a day. And by the end of that, my body is in excruciating agony. I've sat with big pain. And I can get a little machismo around that. And one of my pain patients early on, as I was sitting with this, called me on it and said, Yeah, but you could get up. I couldn't get up, you know? And so what it did was it pushed me into that bigger humility, that this is a struggle. There are skills here, but it's a struggle of bringing the dignity of our humanity to bear on the challenge of our life. It's not to bypass that struggle by pretending that there are tools that help all the way. There are tools that make it better, that make it easier, that make it tolerable, that make it possible. But in the end, it's two humans sitting in a room trying to help one another face the rawness of what it means to be alive. And so neurons on a page is information. And then how do you live is the real matter, the real heart of the matter. Anybody have any questions on this or good metaphors? Dr. Wilson? Yeah.
Say something real quick. And yeah, just call me Josh, please.
Yeah, on mic too, please.
I had the pleasure of being trained by Dr. C here. And one of the things I recalled starting to do every time I went into the room with a physician to see a patient was I'd ask the patient, what makes life worth living to you? I don't know if you've ever been asked that question in this room by your primary care provider, but I think it's important. And I want to know what all this is in the service of. And I can't tell you how quickly there was a shift in the room. And it was just nice to see what kind of dialogue unfolded and how, whether it was chronic pain or other kind of medical issues, were all of a sudden all tied to the core value of the particular individual sitting in front of them. And now at this point, I ask almost every single person who walks into my office that during the intake session, because I think it's just a critical question. And I just wanted to name that because it was nice in an integrative healthcare setting to see the marriage of psychology and some of the other physicians working together in a really collaborative effort to find ways to get better health outcomes. And to what you said, Michael, I'm a big ACT proponent, as you know. Just participate in life as much as possible in a way that's consistent with their core values. So all of a sudden, the medication regime that they were a part of wasn't just to manage pain, it was to see my granddaughter graduate high school. And that became the dialogue. And there was a real shift throughout the whole course of their care that I thought was really positive. So I just wanted to name that and also say thanks for that, Dr. C.
Thank you. Not to get too verklempt, that's incredibly meaningful. Thank you, Josh. I don't know if anybody else have other thoughts or metaphors they like to use when they're talking about this, or ways that they've seen it be effective, or fear about doing it, because it can feel scary sometimes to enter into these places with people.
Could I piggyback on what Joshua was saying? The problem of one of the clients that I have is he has multiple physical problems. Yes. Type 1 diabetes, liver problem, kidney problems. I mean, he's a mess.
He's really suffering. That's big.
He's big time suffering. If he were asked the question that you asked, you would, if his docs were asking him that question,
yeah,
I think there would be a link and he would hear what they're saying, but he pretty much dismisses them. And I try to play go-between, which is a tough job.
It really is. And I think that the docs asking those questions is really important, because what we find in pain management is that you want to put functioning first over pain management. We'll talk about that later. And as Viktor Frankl said, so powerfully, the human can survive any what if they have a why. But the inverse I find also true. If I don't have a why, it becomes really hard to survive, And I've seen sometimes people will go through these health crises. My metaphor in my brain is like you've been on a sailing ship and you're going through this crazy storm. And so you start to throw everything overboard just to keep afloat. Everything in your life is kind of gone. And then the storm kind of stops for a minute, or you're stable. And then it's like, where is my life now? And you maybe even not know what matters to you at that point. And doing some of that heartbreaking deep work of kind of bringing in some of those meaning, what really matters, how to kind of find those places is really important. And we have actually, as our assessment form, we have people talk about their pain goals almost every time. And it makes a very big difference to talk about their pain management goals. And it can also be very funny. I mean, I've had patients say things like, just, I can't think of any. There's one recently. I can't think of it. Barbara, it looks like you're going to say something that you're on mute. I wanted to hear that.
Yeah, as part of our initial assessment too, we ask our patient to identify what's worth living for, and we stress, that this pain medication is to help you function and achieve a meaningful life. So they get that message at the start. And you're so right. When I have patients in the group visit, so many of them are just sitting like a lump at home, and the only thing they're thinking about is the pain. So there's no distraction signals whatsoever. So we talk about how to, build a meaningful life.
That's beautiful, Barbara. And I think when I look at like what has helped me in my deepest heartbreak moments in my life, it almost always boils down to someone seeing more possibility in me than I saw.
Yeah.
And being able to be with it and to bolster me in my pain and to bear witness to it. So I'm glad you're with people and in that challenging, deep place of helping people feel loved in the unlovable places.
Well, the beauty of it is that a lot of times in the group visit, it's other patients that are talking about what's possible for the patient who has no purpose or no distraction. So I don't really have to do a lot of the work. And I think a lot of times when it comes from other patients, they're much more credible than you are as the healthcare provider.
That is real talk. Talk from the trenches on that. I'm a group therapist too. I'm a big believer in that. And I think that there's things that happen in group that provide opportunities for growth and attachment that don't happen in other settings. And I over the years, I've been saying, like, therapy is almost too big to do. There's so much in it that's raw and deep about humanity. And having other minds to add to the wisdom than my own feels more right in a certain way. It brings something in. I'm not saying that individual is bad. I do it too, but it's just, there's something very rich about a group context that often gets overlooked. So I want us to go ahead and watch. Has anyone seen this particular talk? Maybe Dr. Wilson has. Okay. So I want us to go ahead and watch this talk. It's about 7 minutes. It's one of the leader. Hi, Teresa, and hi, Daniel. I want to say welcome. Please feel free to share as much or as little as you'd like. I'm glad that you're both here. If you want to just say hi to everybody, so your seat's in the room and you know there, or you don't have to. If you want to unmute, feel free to say hi.
I think Teresa said hi earlier.
Okay, okay, good. All right, so we're going to do this, and we're going to stop the share, which was the problem last time, and then start the share. And here we go. Good. So this is a gentleman who runs, I believe, the pediatric pain clinic in Stanford. And there's quite a few things in this talk. I've listened to probably 10 times. I still get maybe 5 or 6 things every time I watch it.
I'm a pediatrician and an anesthesiologist, so I put children to sleep for a living. And I'm an academic, so I put audiences to sleep for free. But what I actually mostly do is I manage the pain management service at the Packard Children's Hospital up at Stanford in Palo Alto. And it's from the experience of about 20 or 25 years of doing that I want to bring to you the message this morning that pain is a disease. Now, most of the time you think of pain as a symptom of a disease, and that's true most of the time. It's the symptom of a tumor or an infection or an inflammation or an operation. But about 10% of the time, after the patient has recovered from one of those events, pain persists. It persists for months, and oftentimes for years. And when that happens, it is its own disease. And before I tell you about how it is that we think that happens and what we can do about it, I want to show you how it feels for my patients. So imagine, if you will, that I'm stroking your arm with this feather, as I'm stroking my arm right now. Now I want you to imagine that I'm stroking it with this. Please keep your seat. A very different feeling. Now, what does it have to do with chronic pain? Imagine, if you will, these two ideas together. Imagine what your life would be like if I were to stroke it with this feather, but your brain was telling you that this is what you are feeling. And that is the experience of my patients with chronic pain. In fact, imagine something even worse. Imagine I were to stroke your child's arm with this feather, and their brain were telling them that they were feeling this hot torch. That was the experience of my patient Chandler, whom you see in the photograph. As you can see, she's a beautiful young woman. She was 16 years old last year when I met her, and she aspired to be a professional dancer. And during the course of one of her dance rehearsals, she fell on her outstretched arm and sprained her wrist. Now, you would probably imagine, as she did, that a wrist sprain is a trivial event in a person's life. Wrap it in an ace bandage, take some ibuprofen for a week or two, and that's the end of the story. But in Chandler's case, that was the beginning of the story. This is what her arm looked like when she came to my clinic about 3 months after her sprain. You can see that the arm is discolored, purplish in color. It was cadaverically cold to the touch. The muscles were frozen, paralyzed. Dystonic is how we refer to that. The pain had spread from her wrist to her hands, to her fingertips, from her wrist up to her elbow, almost all the way to her shoulder. But the worst part was not the spontaneous pain that was there 24 hours a day. The worst part was that she had allodynia, the medical term for the phenomenon that I just illustrated with the feather and with the torch. The lightest touch of her arm, the touch of a hand, the touch even of a sleeve of a garment as she put it on, caused excruciating, burning pain. How can the nervous system get this so wrong? How can the nervous system misinterpret an innocent sensation like the touch of a hand and turn it into the malevolent sensation of the touch of the flame? Well, you probably imagine that the nervous system in the body is hardwired like your house. In your house, wires run in the wall from the light switch to a junction box in the ceiling, and from the junction box to the light bulb. And when you turn the switch on, the light goes on, and when you turn the switch off, the light goes off. So people imagine the nervous system is just like that. If you hit your thumb with a hammer, these wires in your arm that, of course, we call nerves, transmit the information up to the junction box in the spinal cord, where new wires, new nerves, take the information up to the brain, where you become consciously aware that your thumb is now hurt. But the situation, of course, in the human body is far more complicated than that. Instead of it being the case that that junction box in the spinal cord is just simply where one nerve communicates with the next nerve by releasing these little brown packets of chemical information called neurotransmitters in a linear one-on-one fashion. In fact, what happens is that the neurotransmitters spill out in 3 dimensions, laterally, vertically, up and down in the spinal cord, and they start interacting with other adjacent cells. These cells, called glial cells, were once thought to be unimportant structural elements of the spinal cord that did nothing more than hold all the important things together like the nerves. But it turns out the glial cells have a vital role in the modulation, amplification, and in the case of pain, the distortion of sensory experiences. These glial cells become activated, their DNA starts to synthesize new proteins which spill out and interact with adjacent nerves. And they start releasing their neurotransmitters. And those neurotransmitters spill out and activate adjacent glial cells and so on and so forth, until what we have is a positive feedback loop. It's almost as if somebody came into your home and rewired your wall so that the next time you turned on the light switch, the toilet flushed 3 doors down, or your dishwasher went on, or your computer monitor turned off. That's crazy, but that's in fact what happens with chronic pain, and that's why pain becomes its own disease. The nervous system has plasticity. It changes and it morphs in response to stimuli. Well, what do we do about that? What can we do in a case like Chandler's? we treat these patients in a rather crude fashion at this point in time. We treat them with symptom-modifying drugs, painkillers, which are frankly not very effective for this kind of pain. We take nerves that are noisy and active that should be quiet, and we put them to sleep with local anesthetics. And most importantly, what we do is we use a rigorous and often uncomfortable process of physical therapy and occupational therapy to retrain the nerves in the nervous system to respond normally to the activities and sensory experiences that are part of everyday life. And we support all of that with an intensive psychotherapy program to address the despondency, despair, and depression that always accompanies severe chronic pain. It's successful, as you can see from this video of Chandler, who 2 months after we first met her is now doing a backflip. And I had lunch with her yesterday because she's a college student studying dance at Long Beach here, and she's doing absolutely fantastic. But the future is actually even brighter. The future holds the promise that new drugs will be developed that are not symptom-modifying drugs that simply mask the problem as we have now, but that will be disease-modifying drugs that will actually go right to the root of the problem and attack those glial cells or those pernicious proteins that the glial cells elaborate that spill over and cause the central nervous system windup or plasticity that so is capable of distorting and amplifying the sensory experience that we call pain. So that I have hope that in the future, the prophetic words of George Carlin will be realized, who said, "My philosophy, no pain, no pain." Thank you very much.
Yeah, I don't know if anybody has any thoughts or reflections on this. Anything that struck you about Chandler or the process? So, oh, thanks, Sal.
Well, it's a very hopeful note. And I'm going to watch this video again a few times.
It's good, and we'll talk about this later, but the three kind of big components of the Y model of pain management, pain neuroscience education is one of them. And it's hard to get patients to buy into doing the work of getting it, but there's a new metric in statistics that is a lot stronger than a lot of our current statistical methods that we often haven't learned, but is a big one. It's called the number needed to treat. And what this is the number of cases that you need to actually treat before you get a positive outcome. Gabapentin is fairly universally prescribed at this point for people with centralized pain syndrome, and like allodynia, and it has a 1 in 16. You have to treat 16 patients before you get one positive outcome. Pain neuroscience education is not a treatment that's standalone, but it has a really positive impact, and it has a 1 to 2 number needed to treat. That means all you need to do is treat 2 people to get a really positive outcome. It should be everywhere. So I'll just encourage you to learn how to do some of this education and even do it for yourself, because often it may help you at some point stop a pain flare-up from turning into chronic pain.
Can I ask a quick question about what you just said about the gabapentin? So I had quite a few patients who were prescribed gabapentin as an alternative to some other anti-anxiety medications. So when you say it's a 1 in 16 to have a positive, are you referring specifically to pain management or in general, some like other?
Yeah, gabapentin is used in a lot of different ways. And one of my arguments as a psychopharm teacher would be for the opposite of polypharmacy is what I would say is effective targeted pharmacy that gets a bunch of things. So gabapentin may by itself treat chronic pain. It'll have an impact on mood regulation and stabilization and can help with sleep and some other things that it can use in epilepsy for sure. And so if you can find that sweet spot where a med does multiple things, when you have a case like Saul was talking about, where you have multiple conditions, that's the opposite of polypharmacy from my view. And I don't know what the NNT is for gabapentin for the other things. I do know it for chronic pain. Great question. So here is the Y model of pain. I got these from the directors of the, got this model from the directors of the Kaiser Pain Management Clinic 2 years ago when a couple students and I went down and presented at CPA. We had a great talk. They really liked our work and we liked theirs. So and they developed this Y model as an anchor, as a map, and I'm going to use it as a frame for us to talk about today. If we're going to do good pain management, pain neuroscience education, everybody should get, and they should get it first. Because understanding that pain is in the brain, every pain is in the brain, nobody is faking pain, there is no made up pain out there. Nobody is psychogenically making pain exist, but that because pain is in the brain, there are things we can do to use our brain to unlearn pain. And you don't have to make it rhyme, but I can't help it. There's another lovely group called Taming the Beast. A lot of the best research in pain is coming out of Australia these days. And that's the Australian physical therapists are really doing great work, even in psychological application of pain, frankly. Tame the Beast has some really good videos on how pain can escalate and some teaching stuff for patients. And pain neuroscience education, we'll go into some details later. It has a few components. We'll talk about what those components are. But the general gist is to understand how people can have more power over pain, how neuroplasticity works, and how people can unlearn pain. And also to understand the fact that pain is a part, that to move from this idea of one silver bullet to a broader area. So I'm going to give a central metaphor that I use for a lot of patients at this point, and it comes from the Pain Society of America, I think. And it's called the 4 flat tires metaphor. And it goes like this. When you have chronic pain, it's like you have a car with 4 flat tires. Pain medicine is one of those, it fills up one of those tires. What fills up those other 3 will take some thinking and some hard work. There are a lot of things that we know help fill up those tires for other people, and we have good research that shows that it helps. But everybody needs to find an individual and personal plan to fill up those other 3 tires. And there's a nice short video that I'll sometimes show patients. It's very dorky, but it also is right to the point to help with this. But once you have pain neuroscience education on board, which we'll talk in more detail about later, then the next thing you want to do, and these 2 could either happen in any sequence, are begin to build those functional goals. What are we moving to? More often than not, I'm sitting with somebody who says, I have always wanted to be a peer leader at my church, and I feel like my pain has stopped me. Or I want to get on the ground and play with my grandchildren sometimes. Or I want to be able to garden. And when we figure out what those things are, we can start to improve function, and setting those goals are important. And then you want to build the treatment team. And the next big thing is to work on pain catastrophization. Beth Darnall, one of Stanford's wonderful leaders on pain. Some of you who've been around for pain may know her. Her books are phenomenal. Her spirit is phenomenal. Sometimes when I see people get famous, I don't always feel like they deserve it. She deserves it. She's got her heart in the right place and has really done wonderful stuff. And one of the things that she's working on now is renaming pain catastrophization, because there's a lot of patient blaming in that word. And she's doing a study asking patients to come up with a more whole way of doing that. And you can hear her ethic and how she does her work in that. It's a really good ethic to try to embody, putting patients first, making sure that we don't have the iatrogenic impact of naming things in ways that rob people of their power. But if you can decatastrophize pain, it can help. And in the packet that I sent with this, there's a scale that we give to all of our patients called the pain catastrophizing scale. And it has components like rumination, magnification, what's the other one? It's anxiety, I think, or anticipatory anxiety might be the other one. And so we give it to those. And if it's high, we know that our biggest work with that person as a health psychologist, and frankly, now that our medical doctors work in this way too, as the medical doctors, if we hit that target, everything else becomes easier. And part of decatastrophizing pain is being able to have somebody trust that they can sit with it. They don't have to love it, but they can make friends with it. And oftentimes, I'll just point blank ask somebody, how many times have you felt this pain before? You know, it's been here so many times. Let's try to find a relationship with it. One of the doctors I work with, she'll say to me, I don't care what the heck you ask somebody, but if you don't ask them what their relationship is with pain, you're useless to me. She also feels the same about medicine too. What's your relationship to your opiates? What's your relationship with pain? That's Dr. Wadley. She wouldn't mind me saying that. If Josh knows her probably a little, if I remember properly. And she was doing pain management before it was a thing, about 30 years ago, trying to really find a way to treat patients responsibly, not just giving opiates, but giving people good care. And then the next one that we may not be aware of as a possibility is pain exposure and strengthening care treatment. So I'm not going to ask you all to become experts on pain exposure treatment. Oftentimes as a physical therapist, but you could ask if a physical therapist can do it. But what we can begin to do is help patients get the principles of pain exposure. And it's just like anxiety. If I say, what is it? Anxiety with response inhibition, right? You know exactly what I'm talking about. And pain is the same way. One of the metaphors I'll give for patients as I'm telling this, and I always phrase it like this: this is a low story, it's a dumb story, my pain is not like yours, I understand that it's different. And this is a story that hit it home for me, how this exposure can work. I somehow got rerouted to get to Denver on an airplane flight through New York, and it took me 2 days. It was an epic journey to get to Denver from which should be a 45-minute flight in that manner. By the end of it, I landed at my meeting just in time for the meeting to do the mile walk with a blister this big on the bottom of my heel. Now, I'm an obstinate cuss, and it was in a place in Denver that there weren't good Uber and all of these things. And so I just walked there anyway. And what I found I was doing was I was walking on the ball of my foot. I did the same thing on the walk back. And because I'm an obstinate cuss, I did it the next morning. By day 2 of this training, my upper back was hurting and my lower back was hurting. And I was in near agony, not from the blister, but from what felt like sciatic pain shooting down my leg and in my upper shoulders. Because I did pain management for a living, I had this radical thought. I had gotten moleskin by then. I put in blister bandages on. I'm not re-triggering it. My shoes are now comfortable shoes. And I was able to change my socks because I no longer was in an airport for 48 terminal weird hours. So I wasn't damaging my foot anymore. I was no longer hurting myself. I was no longer harming myself. The pain was hurting me. And this differentiation between hurt and harm is one of the biggest roots in changing pain management. That if I put my hand on the stove, I need to move it because it's harming. But once pain is chronic, it's not harming my tissue anymore. And so what I chose to do was this kind of semi-radical act of walking normally, even though it hurt more in my foot. Lo and behold, by day 4, the pain in my back and my lower leg was gone. All of that bracing that stacked up from one hip that made me compensate my spine with the other, that made me block my gait, stopped happening. And luckily, by that point, the blister was starting to heal, and so the physical pain in my foot was going down as well. Now, I just wonder what would have happened if I hadn't known that process, if I hadn't been able to help myself do that. And some of the process of working with pain is to be able to help people take a walk with their pain. And it works even better if you can have people do some things that reduce the pain a little bit while doing that. So like maybe you want to have somebody get into a hot pool and do some of their first movement without load bearing. You can even do imaginal exposure to help people gain. Yeah, I'm going to imagine walking out to my mailbox. What do you feel like? Well, I feel like I want to throw up when I think about that. Okay, let's sit with that. Let's regulate that. Let's breathe. Let's relax. Let's use some of our ACT expansion tools to get that dual awareness of pain and not pain. That yes, there's pain in my back, but no, it's not everywhere in my body, to get it localized. That helps. And so we have these 3 components of overall pain management from a psychological point of view, which is pain neuroscience education, so people understand that they can help their brain unlearn pain and that nobody is making up your pain. They don't have to bring in their super amazing slides of the disc problems in their back because you know their pain is there. Depending on the person, I'll say it like that. And then the second thing is to work on functional goals and pain catastrophization. And then the third one is to work on pain movement, just to keep moving, to strengthen, and to do some exposure and tolerance development of the pain itself. One of the things that I'll often say to patients in this is, nope, it left, sorry. If it's important, it'll come back. So this is just a map for this piece, and it's not a map for integrated care. But the big take-home message for this is that pain is complex, and treatment needs to be complex too. There isn't one pain signal in your brain that you get triggered and then you have pain reactions. It's a complex network of things. And so to heal pain, it's going to take that same kind of complex and human-based thinking. And because I sit with a lot of patients of color, oftentimes they'll say, I don't want you to experiment on me, doctor. And we can hear the way that the system has done that. And they'll bring in things like, as a Black person, I know, or as a person of color, I know that my pain is more likely to be dismissed by my doctors and more likely to send me to a psychologist when it isn't right, and I should get the higher level of care. And I'm like, yes, that is absolutely accurate. And I want to make sure we dignify your pain. And I hear that, and I can help amplify your voice in my role. And this is in no way to rob you of that experience, but it is to say that this is the best pain care that we have, is to include some of these pieces in it. And if we can talk about the structural racism, it oftentimes makes people more open to be able to be influenced and be impacted. If I could call out Dr. Wilson for a moment, there's a patient I've gotten to work with for a few years that he would oftentimes say when he first met Dr. Wilson, I was about ready to throw him out on his ear after 2 minutes, but he came in, he sat down and had an honest conversation with me about racism. And after that, I knew I could trust the guy. I knew I could take some effort. And his life has changed dramatically. And his family's life has changed dramatically because he uses the tools that he gets from psychology to strengthen and deepen his family in many ways. And I think what would have been like if he hadn't met a clinician like Josh, who was able to take that humble and authentic stance and talk about it in a powerful way.
Thanks,
Josh. Yeah. Did you want to say something, Josh? I'm sorry.
No, I'm just saying thank you. I actually think I know exactly the patient you're referencing, even though it was years ago. And one of my favorite moments was he went home to his family and he had said, I talk about you all the time. And finally, after probably 6-8 months of knowing this individual, they finally said, what color is this dude? And they said, and he shared that I was a white guy. And they all went, oh my God, you're like partnering with this white guy. And it became this huge, really interesting, complex conversation that he was having with his family. You know, he was having with me, and a trust started to develop between him, his family, and healthcare that hadn't been there. And that trust, I think, was paramount to just how he kind of engaged in a process for himself that was self-healing and self-directed. So,
thank you, Josh. And white people in general tend to not want to talk about racism. And one of the ways that privilege protects us is it blocks us from seeing it in our face as much as we have been watching it lately. But everybody is experiencing it. And so it feels dishonest to not talk about it many times. Oftentimes, naming something that's a truth, even if it's painful, is much more powerful than trying to sweep it under the rugs. And so I'll just challenge us to grow the capacity to have these difficult conversations and do them in a way that matters. And I also want to say, I was mentioning racism, and I don't in any way want to take away from right now, Black people's struggle is in the forefront and needs to be in the forefront and should be the focus and deserves to be the focus. But also women's pain tends to be denied in pain care settings in powerful ways that can lead to escalation of pain. And helping healthcare systems treat women's pain as seriously as it needs to be and unpack their sexism is a very important part about our work. And one of the things that I get the honor of doing is training docs on implicit bias. And we build into this the mindfulness of how our biases may impact us. So we actually have as a skill of being mindfully aware of where we are and how lines of difference may be impacting our thinking. And it's a really important thing that we can do as psychologists is communicate about these issues that providers will want to ignore, that our colleagues may not be brave enough to face. and also that we may feel afraid to face. But if we do it, it'll make the world a more whole place, the way psychology often does. I sometimes think, maybe the reason we don't see as much conversion disorder as Freud did is not that Freud just happened to be in a weird place where there's a ton of conversion disorder, but actually that whatever we've done has gotten more honest. So there's just less need to convert symptoms in that exact way. We're able to talk in a more deep way and they come out in other ways. Maybe that might be psychology's forced cure. I have no evidence for it, but it gives me a little hope for what we might be capable of as we start to help our field be in a place of really serving the people that we want to serve.
Michael?
Yes.
That really rings true with me, what you're saying, that we're in a place where things really can change right now. From my days in public health, in tuberculosis control in the city of Newark, which was the second highest incidence in the country, and it was a CDC project, the chief of the clinic, this was right after the riots, the chief of the clinic, a medical doctor, with whom I was to be the liaison to transmit, he opened his jacket, pulled out his 45, and said, "Those black bastards come in here and I'll shoot first." And I had to work with him. So I know what you're saying from those days all the way to now. Okay?
It's a big deal. And Saul, thank you for your power of spirit that it took to stay engaged at that moment, because I have a feeling, hearing how you talk about that, your patients are really lucky to get you in their life. And his racism could have really put a block to you providing really important care. And I'm grateful it didn't. Thank you.
Yeah, well, it was a cause célèbre to keep up with him and still get him to sign what we needed him to sign.
Yeah. And I just want to say that this stuff is happening all the time. My BIPOC or Black and brown friends experience and are exposed to racism all the time. It's not small, it hurts deeply, and the pain often gets ignored, and we often are not willing to talk about it in a way where people feel held and cared for. And the Buddha had this phrase that called the second arrow when he was describing suffering. The first arrow is the pain, and the suffering is our rejection of self. And he would say that the second arrow hurts 100 times, not double the amount of the suffering that's added on top. And I want to add another layer to that, which is the third arrow, which is when somebody else's suffering was rejected by community and family, that it hurts even worse. And we need to be loved, we need to be seen, and we need to have our pain recognized and witnessed. Witnessing transforms pain. And I think that's maybe the deepest message of mindfulness, is that everything that we have in life needs to be seen. We can't turn away. Painful or not painful, there's a power in us to turn towards it. So I'm going to move. I realize that I'm getting ready to do a hard gear shift, unless somebody else wants to comment on this, and then maybe I'll just give space for someone to comment, because it does feel like too hard a gear shift to go to this slide from where I just.
Should we take a quick break at this point? Like okay, let's take maybe a 5. What do you think? 5 or 10 minutes? What feels good?
Let's do 5. Okay.
Okay.
And I'll see you back here in 5 minutes. It's fun to be in this dialogue with you all.
Same.
Danny, good to see you. I'm gonna run to the bathroom, but I love you, buddy. Just wanted to tell you that real quick.
Hunter, I just want to say thank you so much for being here in the middle of finals week. Oh my goodness. Wow.
Oh, no worries. I think what's been really fortunate for a lot of this year has been how adaptable and flexible my professors have been around the coronavirus and um, the rallies and everything going on. So it's nice to have a little bit of learning that doesn't require assignments, but yes, it's been really, really fun. I'm looking forward to reading more about the sight tasting, the tongue seeing video.
Yeah, it's deep. It's really deep. um, so welcome back, everybody. Anybody have any questions on their heart before we get jumping in, or reflections? Okay. So if you're going to make a really good pain map that really covers from a psychologist perspective, and from a medical perspective, the 5 big things that we can do behaviorally to make sure that we bend the curve on pain dramatically. I'm glad we all have the metaphor bend the curve. I'm going to show my stats geeky self here. Life is much more Bayesian than it is anything else. And the Bayesian analysis has a lot to do with, like, the additive effects of a bunch of things coming together. And pain is like that. If you add a bunch of good in, it kind of overall starts to move the bad down. And that's kind of how we work with pain. So the 5 big parts of a pain management plan are functional improvement goals. These are the meaningful life. Stress management goals, because that closes the gate of pain. Sleep, because sleep fundamentally opens the pain gate, but it also amplifies at a physical level the pain signal as well, and how much your brain is open to it. I will oftentimes try to get the number of hours they sleep, how long it takes them to fall asleep, where, how many times they wake up, and those kinds of things, and how much their pain's impacting them, and whether it's stress, pain, light, noise. And I don't assume that it's the pain, but a lot of time it is. One of the big ones that happens is that if you need to fall asleep, as you're falling asleep, your thalamus will make a brain scanning wave that'll send out and then train your brain into a deeper EEG wave state, which some of us who meditate know from kind of hitting, theta and delta states that have a lot more quiet, or shifting at least from alpha to beta. Did I do that backwards? No, I didn't. Good. But in sleep, it does that as well. But if you get a spike of cortisol, like a big spike of cortisol, that's what happens in the morning when you wake up. You may have had this in the middle of the night when you wake up and your brain can't let go of something. Basically, you probably have gotten your morning's cortisol in the middle of the night, and it's supposed to work that off throughout the entire day. It's the diurnal pattern of cortisol, right? And so if I have chronic pain and I turn in a certain way that tweaks my back, the first place that goes in my brain is to my amygdala, gives me a shot of cortisol. So then I'm up, and then it becomes hard to get back to sleep. And building a plan for that can be helpful. And people can sometimes start to get a pain trigger reaction with their bed, Or if we have working people, the first time they rest enough to feel their body may be when they get in the bed. And that can mean that the first thing they're getting is this mindful backlog of pain sensations. And so some pre-relaxation before bed can be really, really helpful, as is building some ways to interrupt anticipatory anxiety of pain movement. Building great pillow forts can be very helpful. Lots of things to drape the body over, and to bend the knees, and to reduce pressure, and to make the environment solid. So I try to get a sleep plan. Honestly, I'm going to be straightforward with you. When we do our 15 to 20 minute pain assessments, I try to leave every single appointment with a 5-part pain management plan. I most of the time get between 3 and 5 parts. I just want to be clear on that, even in 15 minutes. I know it takes a little bit of work to get to that point, but you can. And then exercise plan, amount, kind, challenges, and then pain impact. And you may have to work with that hurt versus harm thing. And one of the metaphors I get is, I usually give the metaphor of my gym rat friends. And I know that you're only seeing my upper half. I am not a gym rat friend. But they will talk about, they'll talk about the burn that feels so good, the pain of working out. And so there is pain that has to do with strengthening us. And there is pain that damages us. And being able to kind of tell that somatic bodily difference is really important. And just as a disclaimer, it's important that you make sure that you, if you can, kick the tires with a physician to make sure you're not telling anybody to do anything particularly dramatic. Be careful of necks, moving them dramatically, and also remember that sometimes people do have kind of unstable things like unstable balance and gait. And trusting people if they say they don't feel stable is great, and then maybe helping them grieve the fact that they might need to use a walker to move. I have had one of my students at one point finally convinced a patient that even though they couldn't go to the gym, they could weight lift with tin cans, and it was good. And then you want to do some pain management skills, and this is what we oftentimes think about as psychology. But these other things are very important too, and it's like the 3 Ps are pacing, planning, and prioritizing. Our bodies need need rest and exertion, and people with chronic pain need more rest to balance out the exertion. And you need to plan and prioritize tasks. Things like acceptance, cognitive coping, relaxation skills. A flare-up plan is like, so what do you do when you have that pain spike? Maybe you want to reduce your movement, but not all the way because you don't want to become avoidant, right? So maybe reduce by 30%, not by 100. You want to do a little ice, a little elevation, but you may also need some relaxation training, some breathing tools. I've had people that have some capsaicin cream that they put on, or they have their own acupuncture points. They put on their death metal music, which doesn't relax me, but it does relax some people. Everybody's different. Mindfulness practices are very, very helpful with reducing the brain activation and lowering the pain. And it can work somewhat like gabapentin does, and overall lowering the background noise of activation in the brain. But it does it naturally and more stably. And then pain anxiety and self-massage and trigger point therapy can be good. So if you get these 5 parts, you really have gotten a good pain management plan. And in the toolkit that I sent you is both a modifiable and a printable, what I call a functional assessment, which has like all the mental health things I do, things that are common, things that aggravate or help pain. So you can do those assessments. So it has this 5-part care plan on it. And I have at the bottom of mine the triage pathway that's available to me in my system. If you're in private practice, you can build your triage pathway by building referral networks, calling a physical therapist office, ask if you can cross-refer. They'll be so grateful to have your support. Calling a physician and asking them if you can cross-refer, those kinds of things. Any questions on this? Okay. All right, so pain management, and this is coming from the CDC and the NIH, not from me being a woo-woo mindfulness-based therapist. I want to be clear on that. Pain management is pain is a biopsychosocial phenomenon. In other words, if I have love in my life, enough money, and I'm not depressed or anxious, pain is an entirely different condition than if I have those things going on. And being able to see that means that we need to find levers of change that expand people's relational capacity and connection with others, help people break out of social isolation. I have I got to spend some time with Peter Levine recently, and one of the things he said is it's not social isolation. It's not social distancing. It's physical distancing. We need to remain as socially connected as we can. And then the biology of pain. And I want to just remind us that psychology has a biological component. Daniel Kahneman, one of the few people in our field that has won a Nobel Prize. Daniel Kahneman, is that right? Nope, he's the wrong one. Who was the other one? Wears a really cute bow tie, bright eyes, neuroscientist, developed neurons, whatever. Can't get his name. It's gone for now. But he will say that psychology is the biological intervention. And I just want to say that clearly. Psychology is the biological intervention. And this is the man that discovered what neurons were to begin with, just to put him in perspective and how they work. He mapped squid neurons is how he got there. So you want to have any treatment plan be able to help patients adjust to some of these factors. So looking at the biological factors, if somebody has back pain, sexual health can be really difficult. It can make a partnership really challenged. We may have to have these deep conversations that orgasm is not intimacy. We may have to have deep conversations that say, let's find a way that you can talk to your partner about how do you situate pillows? How do you get support? how do you work with what sexuality looks like? Change in diet can have a profound impact. But diet change, if any of you all have noticed during COVID-19, is challenging. There's a tendency for cookie-based coping all the time, and chronic pain makes the tendency for cookie-based coping higher. And then there's an immune response and insomnia. And our social factors are closeness of our family relationships. If somebody has an invisible ability that impacts their ability status, like pain, it can lead to a lot of ableistic aggressions. Things like, get over it, you're weak, what's wrong with you? And so when you start to sit with them to make functional goals, they are going to have the grief of the deep invalidation of our ableistic world in the way of you having a meaningful conversation about how they do that work. And so sometimes I put that functional goal second to talking about and building a positive belief structure around living with a chronic illness and helping people talk about the emotional aggression they've had from family and friends and work colleagues and bosses around their body statuses. And then psychologically, depression and pain co-vary, and they co-create each other, as does anxiety. There's lots of fear about the future. If I've had a nickel for every time that I've heard this, I'd be giving Amazon a run for their money. Not really, no. But the phrase is, I just see my life as getting more and more and more in pain and worse and worse and worse. I don't think I can go forward. You can hear how that, even in somebody who doesn't have depression now, could lead to depression in the future. And you could see how that could lead to suicidal actions. I was just on the phone with somebody earlier today who has chronic cancer pain and was saying, this doesn't feel like my life is meaningful enough to invest in. Now, of course, we've done safety planning enough that I asked her, are you really unsafe? Or are you venting? She's like, I'm venting. Are you willing to follow your safety plan if you're at risk? Yes, absolutely. But at the same time, that feeling that she was having of that deep, hopeless desperation is real. And it shouldn't be trivialized. There are two types of pain that sometimes are mentioned as suicide pain. One of them is called chronic regional pain syndrome, CRPS. That's one of the highest predictors of suicide. And the other one is a trigeminal nerve pain in the face. Both of those are such intense pains that they have a higher rate of suicide than pain does overall. And psychology, particularly for CRPS, is vital in the treatment and the management. Not just because you have to stay alive to get treatment. I want to do a little Linehan irreverence, but also in the fundamental aspects of it. Fear of movement and thinking and attitude makes a big difference, and we can help people find ways to kind of make meaning of these things. Does anybody have any thoughts about these? Anybody tried interventions that they liked, they want to share with their colleagues, or any of this kind of excite you for places you want to take a patient that you're working with or share with a colleague? Going once, going twice. Sold by the silence. I am a therapist. I could sit in the silence forever, but I'm not going to force y'all. It's late. Let's see. Now I have to move the screen. Sorry. My boxes are in the way. Emotional pain and physical pain affect nearly the same part of the brain. So that old phrase that sticks and stones will break my bones, but words will never hurt me, actually is biological hokum. It is not true. Sticks and stones will break your bones, and words will literally hurt you. and we're going to put that into some dollars and cents as we go forward here. So since I know that we have a Shore in common, you may notice some of these biological symptoms are ones that Shore talks about. So I'm going to mention the ones in emotion regulation, and just so that we can become friends with them. Our insular cortex, if you've ever felt the physical symptom of sadness, the heaviness in your chest, or that rise of anger that sometimes shoots up from the gut into the face as your face glows red, right? Or the terrible shakiness in your hands and your legs and that weakness that you feel when we're afraid, right? Or the expansion of heart that happens when you first feel or see someone that you love or care about, right? These all come up. That physical part of the sensation is your insular cortex. And your insular cortex is somatotropically organized, just like your, but it has an emotional overlay and a physical pain overlay. When you ask someone to be mindful of their emotions, you're evoking the insular cortex and helping it grow a new process of being with interoceptive awareness. Now, with chronic pain, you'll see fundamental alteration in the structure of the insular cortex map. So while it's a core emotion regulation center, it is also a core pain center. The periaqueductal gray that we see down here, that goes to your amygdala, and that does the descending control, but you can see the relationship is there. You'll see changes in your amygdala, which has grown famous over the years as much as any brain structure can. The basal ganglia, which does fine motor movement, emotional set point. Most people don't hear that with that, which is why Parkinson's disease is so depressing, because the basal ganglia is involved in emotions. And the prefrontal cortex, particularly that orbital medial and the anterior cingulate cortex. Many times we only think about about mirror neurons for modeling emotions. But one of the things Shore will often talk about is how the anterior cingulate cortex is right now modeling my emotional state while I'm modeling yours, and we're in a tight co-regulation process. And that's not through mirror neurons, that's through the structural process of co-regulation that's built into that emotional system. And that happens when you're in therapy with people with pain too. Your ability to keep your seat, as they say in therapy training, and provide that context of a self-regulating other that can endure the pain of another person with an open enough a heart that it can impact, while regulating and providing back that metabolized aspect of affect so someone can begin to internalize this working model of capacity, grows the anterior cingulate cortex, the insular cortex, and the prefrontal cortex. And these systems are impacted by ACEs. These systems are impacted by exposure to chronic environmental stress from racism and poverty. And these systems are impacted by developmental trauma. And these systems are impacted by neglect. And so it's just important that we know that the pain systems, both at a high and low level, overlap with the physical symptoms. And so this is another small slide on this. And what this is showing is how that neurons are learning machines. I'm not going to go through the layers and how they work. I could. It's actually kind of worth knowing at some point, but it's not worth the time today. Cross-wiring happens through synaptic plasticity, poor inhibition of pain and increased pain sensation. And these changes function like an amplifier on pain. Over here on your right is an image of the Shore model of these kind of core emotion regulation systems. One is, or the orange is orienting to an emotion, noticing it. So right now I feel that slight, maybe not even slight, amplification of stress in my face of wanting to do a good job for you all, and tightness in my chest, but yet some warmness in my lower back, right? So I'm orienting my emotions. The automatic emotion regulation that happens in these deeper brain structures, that once people have internalized the object of the therapist and the process of therapy, those in deep brain structures grow their own capacity to regulate. And then that voluntary emotion regulation when people use cognitive skills or practice a mindfulness skill or breathe. These are all our emotion regulation skills. And if you look over here, you can see the overlay of the impact of the pain structures on the left-hand side. You see the insula, you see the ACG, you see the thalamus, you see the amygdala, the prefrontal cortex. These things directly overlap. I learned about these structures first from Alan Shore, and then recognized them when I started to do pain management, to know that we're in a deep process of developing somebody's neurological self-regulation capacity when we help with chronic pain. And more often than not, when I meet somebody with chronic pain, they have a tremendous history of trauma. And oftentimes trauma is the ontogenesis for pain. And a lot of times when you process the trauma itself, the pain's strength reduces dramatically on its own. We piloted a couple of years ago, along with doing a more structured behavioral approach to pain, something we call the life experiences review. And what we would do is we would put some skill development and then ask people about their relationship with pain, and then draw their relationship with pain on a life map over the course of a life, processing the key emotional points. And we found, lo and behold, the emotional and the connected and the relational processing actually was pretty darn good compared to the other group. We were not in a place where we had enough to study or to publish, but we were enough that the anecdotal evidence was strong enough that I still teach it. And so if you feel like you're doing nothing in those relational places, remember that you're doing that deep brain work of growing with somebody. And remember that monkey that had to grow its ability to have a body map took about 12 weeks, couldn't speed it up beyond that. As you're a therapist, there's going to be some amount of connection with you that grows these body maps. And it oftentimes grows, and then the system is eventually strong enough, oftentimes after a tipping point, that it can then regulate on its own. But you may have to grow a lot before you get to that tipping point. So, steady change to pointillized change to steady change to these dramatic changes, And so here's an overall map of all of pain management. And that's documents that I shared with you. All of these things, each one of them are given at least a 1-page in the training manual that I have for patients that you can use to give them handouts. But these are all things, if someone says, I'm providing evidence-based care for pain management, these are the evidence-based care processes. And I want to point out that this lower quadrant here of the medication area are the opioids. And this is what most people believe pain management is. And this is what pain management really is. And helping people work with individual therapy, these are all of the stuff that lie in our camp. We have procedures and nerve blocks and orthopedics and neurosurgery and TINS machines that you can almost buy. You can buy over the counter now. They're not the strongest TINS machines, but they're pretty good. And people who love them, love them. And movement therapies, warm pool and exercise, Tai Chi and yoga. My physical therapy team came to me 2 years ago and said, actually, we're starting to really teach yoga, or we're starting to really teach some Tai Chi for our knee pain patients because it's better than physical therapy. That's what the data shows. Kind of crazy. But that was somebody providing evidence-based care. An anti-inflammatory diet, we haven't talked about it, but inflammation and pain dance together. Chiropractic, acupuncture, counter strain, these are all part of pain management. So here are 3 kind of anti-pain psychological skills and toolkits. One of them is pain acceptance and building the ability to accept. And remember, accept isn't saying it's right or has to be there permanently, but it is saying that it is here now. And how do we find a relationship with it? Have you all ever done creative hopelessness with patients? Has anybody here done creative hopelessness? Creative hopelessness is like this. We know it from a lot of the mindfulness images of have tea with your emotions, right? Creative hopelessness goes like this, is that it's like if I walk into a room and I deny that there's a table in the room, I'm going to bump into it all the time. It's going to hurt. If I notice that there's a table in the room, I can start working with it. So the fact is that if you get your car and it's in the ditch and you try to pretend your car isn't in the ditch, it isn't going to help. But if you let yourself be hopeless that it is in the ditch, you can then begin to find a workable way to get out of the ditch. That's the heart behind it. And so what we can do is say, your pain has been here for a long time. It's here today. How do you feel as good as possible in spite of everything? I'm a Zen practitioner, and koan study is a big part of my work. And this isn't an active koan, but it has a lot of koan elements in it. Do you all know the strawberry story? Yeah, so it goes like this for some of you, and if you can be bored, and I'm thankful for those who've heard it for enduring it. It's not a very satisfying story, but it's a true story. And that not that the facts of the story are right, but it tells the truth about life. A man is walking through the woods, or a person is walking through the woods. Let me not be binary if I don't have to. Stumbles upon a tiger. The tiger begins to chase the person. The person runs away from the tiger. And as they run, they come up to a cliff edge that they can't get away from. Either they turn and face the tiger, or they go to the cliff edge. Tiger seems like certain death. The cliff edge seems like it's a possibility. So the person leaps off of the cliff edge, and thank goodness on the way down, they catch a vine, and they look up, and just above them, just out of reach, and the tiger can't get them, is the tiger pawing at them, and they breathe a sigh of relief. And just then they look down, and it's not that far, and they think I can make it, and lo and behold, the tiger comes from below. birth and death, here we are in the middle of life, always chased by these stressors. And creative hopelessness happens when the man in the middle of the cliff edge looks over to his left, or the person in the middle of the cliff edge looks over to their left, and they see a strawberry hanging on the vine nearby, and it's juicy and it's sweet, and they pick it and they eat it and it's good. And this is us, always in the middle of life, always broken open, always afraid, a little, right? Always struggling. And yet there's ways that we can find sweetness. And 9/11, the people who didn't get PTSD had what Barbara Friedrichsen would call granularity of positive emotions. What she meant by that was they noticed the small blue skies, the puppy that was saved, the family that knew about their dead loved one and could rest, even though their loved one was dead. This small turning towards possibility was transformative. And pain is like that too. The creative hopelessness of finding those bright strawberries, even though we're chased by the tiger of pain on one end and the other, is powerful. And another tool is mindfulness of pain itself. If you know, the pain cycle goes like this, it goes everywhere in your body and your brain doesn't localize it. And then your brain localizes it. And then your brain turns it off. The neurotransmitters that turn it off are often norepinephrine, serotonin, and oxytocin. I know oxytocin is a peptide, not a neurotransmitter, but will, give me the latitude. So if you pet a dog, it will have a fundamental ability to reduce pain because it has that quality in there. If you get a hug from a loved one, it will too. And a brain scanner, if someone is holding the hand of someone they love and loves them, the pain centers in the brain light up less than if they're not. So one of the things we can do with what happens in a pain cycle is just like with trauma, it doesn't end its completion of the protection cycle. With pain, you may not get the full cycle of the pain. The person may be stuck in that global experience of pain. Where do I hurt? I hurt everywhere. Sometimes that's a centralized pain syndrome, but sometimes that needs the mindfulness of being able to describe in detail the borders and the outline of the pain. So when I'm sitting in meditation and my knees are burning like I'm going to throw up, which I've had happen, and it feels like my entire body is lit up by pain, when I notice it, when I can really do that force of mindfulness down to the knee, oftentimes my pain is this big. And it stops being the entire body. And at the point that it's not the entire body, it's not that it's less, it's not that it's more manageable, there's just more me. There's more self to the pain relationship. And then that's what mindfulness of pain can grow. Hard conversations to have. Trungpa Rinpoche uses this phrase of touch the emotional pain and move off. Don't get stuck there. And I would say that that's a powerful tool for physical pain too. Touch the physical pain and move off. You're not afraid of it, and you know you can shift your attention. You're accepting it, and you're being able to shift back to life. Alrighty. And I didn't mean to do that. And the last one, the last two skills here are pain meaning and pain relationship. And then the next one is making sure you move your body and building a plan to move your body. Tai Chi, Feldenkrais, all these wonderful things are great. I'm personally a great explorer. I love to check out anything. So I would suggest try things before you sell them to others, before they're worth doing, or it can be life-changing. So these are the four kind of big areas that I'm going to work with when I'm working with pain: physical health and function, neuroplastic brain change, spiritual meaning, and emotional well-being. And here are some, if I were to be making up kind of an overall pain treatment plan, here's what a pain treatment plan might look like. We're going to address some of the physical issues. I'm going to get them to their doc. They're going to develop physical strength and endurance. We're going to have that 5-part pain management plan. We're going to make a goal. We're going to talk to them about how the brain chemistry changed. We're going to talk to them about the meaning and purpose in their life. I had one afternoon, I was with a patient and a student, and the person was talking about an intractable pain. And then we just asked her a little bit about her spirituality, and she told us about an event that happened that transformed her life when she walked up to the front of one of her Christian services and felt perfused through her entire body and what she felt like was everywhere in the world, an experience of divine love, acceptance, and appreciation. She said she'd never experienced that again, but had forgotten about it and swept it away. And as we sat there and talked about it, it felt permeating the room. Her light changed in who she was. She began to glow. And honestly, she shifted the course of her care quite dramatically that day. And the student and I walked out after that session, and we kind of had this look at each other and almost simultaneously said, what the hell just happened there? That was something quite profound. These kind of spiritual and transcendent states do exist. and they are important to not put on the outside of therapy. A lot of times mindfulness, we oftentimes talk about the awareness practice itself, but forget that transcendent kinsho of intimacy with all beings as being one of the things that happens in mindfulness. And there's plenty of good data that it happens from brain scans on out. So here's the big goal. We want to move somebody with a small life with a big pain to a big life with pain. And the more you can do that, the easier things get. Let's see, where are we? So here's Jane. She's a 35-year-old Latinx, cisgender, female identified, straight woman who works as a computer engineer. She has 2 children and a spouse who's supportive, who doesn't really understand her pain or her mental health needs. She had a major fall during training to be a volunteer firefighter after the Santa Rosa fire, and she's had 3 surgeries since then. She has a diagnosis of PTSD. Her therapist believes that her pain is triggering a trauma response. And she grew up in a stable and loving home, that she reports. However, she says people were perfectionistic, her parents were, and didn't allow her to make mistakes. She has become more and more irritable since her fall, and it's impacted her functioning at work and made it hard for her to engage. Just hearing some of the things that we've talked about, what might be either some assessment questions, some interventions we might want to do, anything that we might do to kind of help Jane find more connection or function and purpose. We can think about it. This was when I was going to do breakout groups, but I think we're small enough that breakout groups wouldn't make sense. What might be some treatment targets?
I would have to hear more from her. I don't quite know enough. If I were interacting with her, I would let my own felt sense in my body what you described before, the painter and the brush would lead.
Yeah, that's right.
That kind of feeling needs to be there to
It does.
guide me through this.
Me too.
Yeah.
Thank you for that. Yeah, and I can't, sadly, I can't evoke that in a vignette. I think that's one of the
No.
in therapy.
And perhaps if I were listening more attentively when you started describing her, and I weren't busy thinking about what you said just before, then I would have had the empathic connection. But without it, I'm lost.
No, thank you for that. I so appreciate that. And I think what I'll take that as feedback is maybe I'll put a picture with the next one, and I won't just put clinical data when I do this again. I'll make sure I describe her from my heart a little more. This was a very clinical data presentation.
Yeah.
Thank you for that. I really appreciate that. So when she walks in the room, she feels solid and strong. When you look at her, she kind of has this presence of somebody that commands the space. You get a sense that her household runs well. And you get a sense that she doesn't suffer fools. There's a sense also of tension that kind of resonates off of her, and her eyes have a little bit of a hollow feeling. Barbara, so what were you, Barbara? It looks like maybe you or Josh were having some thoughts.
I have a lot of thoughts. One of the things I want to know is, so how is her current physical status affecting her ability to work, to take care of her children, and how has this changed her relationship with her spouse in other ways besides the spouse appearing to not really understand her pain or her mental health? And of course, I also want to know more about what was the experience that led to the original post-traumatic stress disorder, because I think that that's very important too. This irritability is often a sign of post-traumatic stress disorder and depression. So for me, I want to, like Sal, I want to know more. I want to find out more about her.
Those are beautiful assessment questions. And one of the teaching ways we sometimes do this in classes, we'll do a pass the stethoscope, where somebody kind of actually does some interventions while you pass it around the room. That one's kind of fun. I do have responses for all of those things with her, but those are the right questions that would start to open her world up in a new way, so that she feels understood.
I wonder, Michael, you said she doesn't suffer fools, and that sort of stuck with me. She was a fool who was not suffered by her parents.
And I think that is going to be one of her meaning architectures.
Yeah, and I would not say that to her, but I would keep it in mind. I would remember it, and I would just tuck it away, and then keep going. But finding out more about her, what is it like to have her household run so well? And and another question I have is, to what degree does she contribute to her husband not being helpful? This is a failure in the relationship.
Takes two to tango.
And only one to stop the dance.
That is, yeah. And if we were playing past the stethoscope, I would say that I feel so angry that he doesn't listen to me about our pain, that I don't feel close to him anymore.
Yeah.
I want to feel close to him. I miss my partner, but I'm almost a little too angry to even miss him right now. Is a little, I might say.
So there's a lot of anger and resentment that has to be worked with.
Yeah.
The other thing is with her parent. The minute you talk about parents, it sounds like you're blaming the parents.
It's true.
And it can be different. I really believe, I believe this. Is there data out there? There probably is. But I believe that people do the best they can at a given moment, given what they got. What's in it for them to do worse? There's not a game there. It's not adaptive in biology. You adapt or you die. So this is not adaptation. So if we can tuck that away and say, well, your mother and father, they did the best they could, but you have to hear the rest of it. And who is having empathy for you? Nobody's having empathy for you. Exactly. Can you and I, both adults at this moment, have empathy for the child you once were? Could we do that? And I think that's for me, I don't know how I came to this, but it happened. And one day I'm saying this to a patient, and I'm going, whoa, that sounds pretty good. I am going to try that for myself.
Yeah, our work does help. It keeps us honest, doesn't it? It actually, I'm a better person because of the things that came out of my mouth. That I'm like, oh, okay, let me practice a little what I preach. Thank you for that, Sveta. Did you have something?
Yeah, I just wanted to. It's pretty much what Sal was saying. I was actually wanting to be a little bit more curious of what it was like for her to grow up with perfectionist parents, and all of this pressure that was probably that she was holding, and to kind of have more of like this empathetic hold for this younger self. And when I was describing that she's being more irritable, and despite of all this surgery, she continues to experience pain. This perfectionist side of her, she no longer feels perfect, right? And so, what is it like to be in this new relationship with herself that is no longer the perfect whole functioning self? So I was going to kind of go with that.
Beautiful line of questioning, and I do think that there's a lot of anger at self for the feeling of the weakness and the vulnerability, and being able to kind of have that. And I my projection towards her is also the grief at her pain, and having the change in her body status. That anger is kind of coupled with that perfectionistic anger, and the pain feels more like an insult, and the trauma makes her feel more like that insult.
Yeah.
It looks like Josh is leaning in a little bit, or somebody else wants to share a thought.
A lot of what's already been said. I was just thinking to like seeking safety protocols even, and just the whole process of safety, grief, and then reintegration. And really just kind of walking through that complex three-stage process would be really critical. Obviously, a lot of psychoeducation for the family. Potentially family or couples work might be an adjunctive component of this individual's care. And one thing I find myself doing with a lot of people who have similar types of presentations, I guess, is maybe have them write a bit of an impact statement, just all the things that have happened throughout their lifespan that has impacted, good and bad, all, that really, really had a profound impact on the way they see themselves, the world around them, and their future, that whole cognitive triad. And then that can oftentimes help me connect the dots or help them connect to their own dots in a way that can help provide a roadmap to what needs to come next. So those were just some thoughts that came to mind.
Those are really beautiful and really important thoughts. I'm grateful for that. That's why the dialogical, I can really feel the power in this group. It's a lot of great healers here. Thank you for sharing these thoughts. There's more here to unpack, but you can start to see that, maybe from her trauma, her hypervigilance may also be some hypervigilance of the pain, because the trauma was from the falls and the surgery. That was the PTSD producing event. And so there's going to be this coupling or this joining between the trauma and that. And so that hypervigilance of body sensation is going to open the pain gate. And we can help with some of those things too. And it feels like, does anybody want to add maybe a final capping thought? There's lots more to this, but you might want to help her with her sleep. You might want to help her get some movement. And you might also look from that social, cultural privilege and oppression dynamics, that as a female, she may not be supported by cultural dynamics to put self-care at the top of the list, and that self-sacrifices at the top of the list due to how sexism manifests in the world, and helping her maybe unpack some of that and building some healthy belief models that her body, her needs, her mind, her spirit are valuable to put as number one, and finding ways to ask for that in ways that are constructive with her spouse, rather than, like Sal said, maybe sitting on the sideline throwing bombs sometimes because of how hurt she is by the dynamics. And maybe her spouse being able to talk about his role in it too.
And I would really want to talk to her surgeon to find out what the surgeon's expectations were about the surgeries, whether the surgeon expects her to continue to experience pain or not after these surgeries, because that's really important too. That can help you kind of sort out the emotion from the biological aspects of pain.
Beautifully said. And it really can. And this is why that interdisciplinary care is so vital. I forget how privileged I am to work in a integrated medical system where I can open up the chart and see the surgeon's note.
Me too,
so I forget to sometimes say it because of that. But oftentimes you can ask the patient to bring the surgeon's report, or you can ping the surgeon with a release of information.
Right.
And you might be hard to get. Some doctors will respond well. Surgeons are a little mixed, but their office will often respond with the data and they can fax it to you. Yeah. Sorry, Daniel. Yes. You're muted. So I'm sure you're saying great stuff, but I can't hear it.
Okay. Hi there. I was just wondering, at any point of your work with this woman, did you do any further assessing as to the level of pain and the level of trauma to earn the diagnosis of PTSD? Because I know there's a spectrum of severity of PTSD and severity of symptoms, and also as well the trauma. So you have the pain and the trauma. I don't know how serious it was with this woman. I don't know what happened to her and what the nature of the PTSD is. So until I have a better take on what that is, I don't know what I'm going to be doing with her.
Yeah, and the PTSD was from a fall where she had a near-death experience, and from the surgeries, and then the time in the ICU. Those are the precipitating events.
And what was the severity of the trauma? I mean, as a result of that, how?
Well, just to be honest, this is an amalgam case of maybe 4 or 5 people who have a very similar presentation. So I'm not going to answer specifically, but the level of PTSD symptoms on, like, let's say a PCL5, like a larger PTSD screener, would have been kind of 45. So it would be moderate, not at the peak, but at the middle of the zone of symptomology, and symptoms in all of the categories, not a pretty broad-based PTSD.
I just wanted to add, if you allow me, one more thing. When in the first part I was talking about her spouse being supportive but doesn't understand the pain and her mental health needs, what is it like, for her to, like, even when she was entering the room and she was carrying herself in a very strong manner, what would be like for her to allow other people to see that pain? And, what will be like for her to kind of almost develop a relationship with that pain that was part of, what we were speaking earlier. Because it doesn't feel like, she's being seen as the pain being part of her.
No, and it's that ability to be vulnerable seems like part of one of her healing. And one of the things that can happen is, if I'm not willing to be vulnerable, I lose a lot of support that could be available to me. And so she may have things that are out there for her that she doesn't have access to. I have a question. Just because I'm a family therapist by nature, one of the questions family therapists often ask is, who needs to be in the room? Would you, in a case like this, maybe bring the husband in for a dialogue about the pain, after doing a little bit of work,
Yeah.
Yeah. And I think that could be very powerful, because you can elicit the partner, and maybe even the kids, if appropriate, as kind of allies in how we do this. It depends on how old the kids are and the structure of the family and those things.
Michael?
Yes, sir.
I also bring in the parents, whether they're dead or alive, it doesn't matter, but what would your mother say about this? What would your father say about this? And it sounds like you're just imagining what mother and father are saying, but you're getting the introjects speaking out and giving you a pretty good mind map of what's going on inside her, how she's beating herself up.
That's true. And you also probably get these kind of warbles of meaning creation and experiential creation that the dyadic therapy process can then begin to write new possibilities of human interaction, Mm-hmm. And I love that question. That's really beautiful.
I will be actually a little bit careful with the question, because, not to disagree, but, if the parents were perfectionists, they might be very critical with her current pain. And so I think the way I'll ask the question is, what would you like your mom and dad to say to you? Because otherwise I'm afraid that the answer will be very critical and very painful.
It could be critical and painful, but that could be, what you said could be a follow-up if it gets messy.
Yes,
well,
exactly.
Or yes. Can you imagine, I can imagine your parents saying such and such, and if I'm imagining that the parents are saying something nice, something seeing, supportive of the child, then those circuits are being activated anyway.
Yes.
So it has that value also, both. But I think we have to be gutsy about not worrying so much about stepping on somebody's sacred feet. If you step, and you say, I'm sorry, and then you repair. Otherwise, we get held back too much, and I don't think that's good.
I love that. That's beautiful. And it reminds me of how deep therapy is. You both are right, and you disagree. that's the landscape that we're in. It's important,
I only disagree in sequence.
Yeah, it's beautiful. All right, so I'm gonna leave Jane behind, and I wish you well with all of your Janes and other cases that are out there. And I love what you say. There's a teacher that I read a lot at one point that he was a spiritual teacher that often say, don't settle for easy answers. And I've lived with that, challenge ourselves to take a risk. And there is a data set in therapy that shows that people who are willing to do clinical risk taking, but also follow it up with empathy and repair, if it does go off the rails, tend to have more outcomes. 2 weeks ago, as the ramp up of the structural violence was hitting, and all these protests and COVID, and I was just exhausted. I had about 4 therapy sessions in a row where I was really unbrave. I chose really boring, not effective things to talk about, and I thought I was helping myself because of my stress level. I ended that day so exhausted.
Mm-hmm. You were holding it all in.
For me. It was a really good lesson for me. What I'm going to jump past the pain education here, because you can practice some of that. I'm going to have 2 more things before we wrap up. No, maybe 3 more small things before we wrap up. This is going to be the thing that you can use as a basic pain education video to help with folks if you want to teach about the overview of pain. This is an Australian video. There's a bunch of them. They're called Brain Man Pain, and they're in a bunch of different languages, depending on the kind of populations you work with. I'm treating a Portuguese-speaking patient right now. It's over telehealth. It's a little bit of a strain in some ways, but also working, and we're growing the development. So here is Brain Man Pain. This is one that I sit with patients and show it and then have a discussion about. Or sometimes if I don't have access to the video, I'll share some of the content with and have discussions about it.
That pain is a universal human experience. We now know that pain is 100% of the time produced by the brain. This includes all pain, no matter how it feels, sharp, dull, strong or mild, and no matter how long you've had it. You might have had it for a few weeks or months. This is called acute pain, and it's common with tissue damage, say from a back injury or ankle sprain. And generally, you'll be encouraged to stay active and gradually get back to doing all your normal things, including work. Or you might have had it for 3 months or more, and this pain is generally called persistent or chronic, because in this type of pain, tissue damage is not the main issue. What's less clear, though, is when you're told you have chronic pain, is knowing what's best to do about it. Well, in Australia, chronic pain is a really big problem. In fact, 1 in 5 people have it. Having a brain that keeps on producing pain, even after the body tissues are restored and out of danger, is no fun. Some people say it still feels like they must have something wrong. But that's just it. Once anything dangerous is ruled out, health professionals can explain that most things in the body are healed, as well as they can be by 3 to 6 months. So ongoing pain being produced by the brain is less about structural changes in the body and more about the sensitivity of the nervous system. In other words, it's more complex. So to try and figure out what's going on, you need to retrain the brain and nervous system. To do this, it's helpful to look at all the things that affect the nervous system and may be contributing to your individual pain experience. What can help is to look at persistent pain from a broad perspective, and by using a structured approach and a plan, it's less likely that anything important will be missed. Let's start with the medical side. Firstly, taking medication can help, but only to a limited extent. It is the more active approaches that are necessary to retrain the brain.
And just to put this in dollars and cents, medications can account for about 30% of pain management. That means if we gave a person every opiate on the planet, they would get 30% of pain management out of it. Psychological interventions get between 20 and 60%, depending on the types and how well they're done and the amount of interventions that go together, just to give you a sense of the power. Now, the sales job on those psychological techniques requires people taking an entirely different worldview. It's not an easy sales job.
So using medications...
Yeah, Josh.
So say, correct me if I'm wrong, but what I recall is even like ongoing opioid use will increase pain sensitivity and make pain worse over time. But the addictive component creates this dependency where people, I don't know, just don't really understand that relationship to it. And it's an important part of the psychoeducational process.
Absolutely true.
Okay.
It's called hyperalgesia. Pain
All right.
medicine creates hyperalgesia. And one of the things that people feel is that when they stop a pill or miss a pill, they feel this major rebound in pain, which is, what happens if you stop methamphetamine is you get depressed, because if you remove dopamine, you're going to be depressed, right? If you remove the opiate, you're going to have a rebound in the pain in the brain. Well, your brain changes its own pain structure. One of the things that I'll say is this is a frame for this, is that when you stop the opiates or drop a dose, you'll have an increase in pain for a short amount of time as your brain begins to help make its own opiates on the inside. And we can do things to help your brain make more of its own opiates and depend less on the medicines. Now, you're going to have an optimal amount of medicines or no medicines, depending on who you are, but we want to make sure that we keep that optimum at a reasonably low dose and make sure it's not the only thing that's there.
It going is okay, and then mostly they can be tapered and ceased. Some people also think surgery might be the answer, but when it comes to a complex problem like chronic pain, surgery may not be helpful. So if you're thinking of surgery, it's best to get a second opinion, and remember to consider all the things.
Just to stop there, you all may or may not be aware of this study, the one where they stopped people in the mall and gave them an MRI of their back or their knee. You know this one? I always feel like with researcher, like I'm a comedian. Stop me if you've heard of this, But what they would do is they stopped people at random, and they found people with disc problems, and they found people with knee problems, and then they measured the chronic pain. And they found, lo and behold, tons of people with knee problems and tons of people with what looked like major disc problems did not have chronic pain, and tons of people who had neither had chronic pain in their knees and their lower back. And so when people come and present the images of the discs, it's not that that's bad, it's just that it's not really enough information. In the same way that someone can come and tell me that they were in a war zone and only 25% of those people will have PTSD. It doesn't mean that that's there, right? We have to kind of be able to have this more complex, more nuanced thinking. But a lot of times people will be given this message by their doctor, because I have an MRI, the pain is for certain a thing. And when you've lived with a health belief like that, changing it can produce a lot of rage. And so it's careful, deep, and very important work to broaden it while not invalidating their pain experience. And so it's a needle to thread, as they say, and you can miss the target on either side quite a lot, but it's worth doing. And oftentimes, if I've done like a course of treatment, and that might be one of the main treatment goals accomplished, I know that by itself will have a meaningful impact on someone's longevity and their life overall.
Next, it is helpful to consider how your thoughts and emotions are affecting your nervous system. Pain really impacts on people's lives, and this can have a big effect on your mood and stress levels. All those thoughts and beliefs are brain impulses too, but you can learn ways to reduce stress and wind down the nervous system. This helps with emotional well-being and can reduce pain as well. The third area to consider is the role of diet and lifestyle. Now, it turns out that our modern lifestyle might not be so good for us. In fact, what we eat and how we live may really be contributing to a sensitized nervous system. Looking at all the things like smoking, nutrition, alcohol, and activity levels, and seeing if there are any issues is a good beginning. And these things can go on your plan. Then there's often enormous value in exploring the deeper meaning of pain and the surrounding personal story. By stepping back and looking at all the things that were happening around the time the pain developed, many people with pain can make useful links between a worrying period of life and a worsening pain picture. For many, recognizing deeper emotions can be part of the healing process. Last, but by no means least, is physical activity and function. From the brain's perspective, getting moving at comfortable levels without fear and where the brain does not protect by pain is best, and you'll gradually restore your body's tissues. So, to sum up pain, it comes from the brain and it can be retrained, and when looked at from a whole person or broad perspective, gives you a lot of opportunities to begin. So, get a helping hand if you need it. set a goal, and begin.
So when I show this to patients, I might show it to them. It takes about 5 minutes, not that long. And I just ask them, which parts of this do you resonate with? Which parts bug you? You know, and we just have a good conversation around some of them, you know, and it can be really deep. You know, they're like, what do you mean that, you know, my mood can impact my pain? I just don't get that. And I say, well, you look kind of frustrated that it might be mentioned. And like, yeah, I feel like you're saying that I'm making up my pain. And then we can have a meaningful conversation around that. Like, no, actually, I don't think you're making it up at all. I think it's very real. It's just this pain gate thing means that if you have, if your mood or your stress is high, it aggravates your pain. So what I want to do is give you every kind of possible tool to have the best life that you can, you know, with this terrible thing that you have to live with. Anybody else want to speak on one of these that grabs you? You might be able to share with a patient or.
Well, one of them is diet. Earlier you mentioned anti-inflammation diet, of controlling what you eat. And there is a diet that was developed nearby one of the islands in Seattle. Actually, this person was practiced in California for a long time. Her name is Kathy Abascal. And the diet consists of 2/3 vegetables and 1/3 protein and grain.
Great.
And as long as you eat in those proportions,
that's right,
and you can eat as much as you want in those proportions, you wind up losing weight because it's reducing inflammation in the body. I tried to stay on that diet myself, and of course I get off it every so often.
That's beautiful. And I talked to a lot of doctors who are diet skeptics,
yeah.
But I think it's because a lot of the research was done that was shoddy. We had our first really solid multi-site study that looked at the Mediterranean diet, which if you kind of add the Mediterranean diet up, it basically is that, right?
Yes.
And we found that, it does reduce inflammation, reduce illness, and increase longevity of it, you know? So these are starting to know that this is an important area, and we're starting to feel its powerful impact. And you know, there's also if you eat better, your microbiome gets better. And if your microbiome gets better, your stress gets lower. But you know, diet change is as complicated as all of human psychology, you know? And so it's really, you know, you can tell somebody to stop using salt, but salt oftentimes has connections with family, with love, with the teenage rebel on the inside that says, screw you, you know, I can have this, you know?
Yeah, right.
And so being able to sit with people in these deep places is very important. And that's how the real change can happen. I'm glad that you're taking that on. And I think that one of the things, if you look at kind of mindfulness practices overall, you know, if you look at yoga, they talk about there are 8 arms to yoga, and the movements is only one of them, right? You know, another one of them is mindfulness. Another one of them is right diet, you know? And the same thing with the Eightfold Path and the 4 truths of the Buddha. The first 3 are the truth of suffering, the truth of the cessation of suffering, and then the process for ending suffering, and then there's the path, right? And that path has to start to do with getting your body right, getting your mind right, keeping yourself in the right view. And so when we start to look at these older traditions, they oftentimes point at this broad biopsychosocial movement towards health. And so, you know, we oftentimes come around to what the wisdom traditions have been pointing at in ways that I think include other things, because I don't think the wisdom traditions were all that great at helping us heal some of the wounds of the past or some of the traumas we dealt with. But I think the dialogue between the wisdom traditions and psychology is really potent and powerful. So we've already mentioned this slide, just so you know I'm not skipping things that are important. The first thing that happens in pain is global activation. Then your brain localizes, and then your brain stops it with serotonin and turns off the pain. Knowing that pattern is really important because it can kind of help you notice where the threat arousal cycle somebody is. I keep assessment questions in my back pocket. It's one of those things that I just want to know, is it kind of like we have a cycle in the background? Well, we don't need to go through this. But if I'm looking at some of the other bigger pain syndromes, you have a bunch of different kinds of pain. I'm not going to name them all. It's worth knowing the broad classes. The broad classes would be musculoskeletal pain that has to do with muscle tightness or bone being out of place. Surgery can oftentimes help, but so can physical therapy. So can, different movement. Feldenkrais would often talk about, the power in movement. And I remember him joking with somebody who had his hips open in a Feldenkrais session. Then he said, your wife and your sexual relationships will be better because your hips are more open now, right? There's all these things that can happen with movement. And I notice where I'm tight in my body, it relates to things in my life. So that's one type. Another type is inflammatory pain, and this is like rheumatoid arthritis or arthritis syndromes. Another type is mechanical pain, and these oftentimes are things like compressed nerves. Sciatica is a mechanical kind of pain typically, and you can practically, sometimes I'll show people charts of where your inguinal ligament is and where the nerves run and how your psoas muscle can pinch that. And then we talk about what tightens up your psoas. If I do that, that tightens my psoas. So if you were to yell at me and tell me I'm the worst presenter you've ever met, I may have a tight psoas and pinch a sciatic nerve, and the next thing you know, I have a pain in the ass for a few days, And then another big class is called centralized pain, and this is where pain gets to be produced in the brain by itself. Fibromyalgia is in this class of pain. The allodynia that Chandler was dealing with is in this class of pain. And it has two things: hyperalgesia, where we become more sensitive to pain overall, and allodynia, or the cross wiring. So you just kind of know that those are two parts of it. There are good centralized pain assessments out there if anybody needs them. I know we may not be the most assessment happy crowd, but they're out there if you want to kind of tease out if there's centralized pain going on. One of the big hallmarks for centralized pain is kind of fuzzy, tingly, sharp, or shooty kind of things. Mechanical pain or nerve pain oftentimes has like kind of a sharp pokiness, and some of the other skeletal muscle oftentimes has throbbing or pulsing is kind of a quality. So sometimes you can get it by the qualities. I wouldn't expect you to remember that, but it's look upable. If you know that it's a thing, you can just have it in your mind and look it up if you need to. So this is a slide that I'll go over with people related to kinesiophobia. Kinesiophobia is that fear of pain that leads to fear of movement from fear of pain. And this is when you have the miswiring in your belief structure that the hurting of pain is causing harm in the tissue. And so the injury leads to pain experience, which leads to catastrophizing, which leads to fear, which leads to avoidance and hypervigilance, which leads to disuse, depression, and disability in a tight cycle. And then accepting our pain experience leads to less fear. I've never met anybody with no fear. I'm not sure it'd be the right way to live. Maybe I'll just show my geek flag, and Dr. Who will say to you, I remember him talking to a kid in one of the shows, he said, your fear is your superpower, kid. You shouldn't be afraid of it. It can make you run faster, jump higher. Don't try to get rid of your fear, embrace it. So, I'm not sure I totally want to, no fear either, but confrontation and recovery. And that process of being in this tight cycle for years can leave the brain into a place where it becomes hard to do this. And a lot of what we're doing is in that way that Vygotsky would talk about scaffolding a child's experience to grow new capacities. Therapy becomes like a cast, or like that scaffolding place where people can try on in a safe place, where they're not as worried about hurting themselves, these new experiences with pain, these new experiences with relationship, so that they can begin to do some of this hard work of challenging their kinesiophobia. And if you really want to get pain management down to just the simple nuts and bolts, you want to improve functioning first and get somebody committed to having a good life. And then you want to work on making the pain as tolerable as possible and as limited as possible. And oftentimes, if you chase the pain, you get more pain and less function. If you chase the function, or the meaning and purpose is what function means, if you chase that deep meaning and purpose of a life worth living, was what Linehan would have, and the pain goes down and the function goes up. It's kind of like just putting things in the right sequence. Oftentimes, we love Maslow for what he did, but he may have gotten it a little backwards. We may need meaning more when we're in survival than we need it at any other time. It may be that simple meaning of heart that says, I'm willing to endure till tomorrow this unendurable thing, because there's something calling me forward, something that wild and wondrous in this life that asks me to be courageous, that really is what is at the root of our fundamental need, or as Viktor Frankl would say, our will towards meaning. We have to have that will towards meaning. So when you look at pain neuroscience education combined with movement has tremendous ability for decreasing pain. And here's that why model again. Just remember, educate about the pain neuroscience, which empowers someone to be their own agent of change, help work with catastrophizing and function, and remember to do some of that exposure therapy. You can do it in titrated ways through visualization. You can do it in bigger ways, have somebody walk across the office, being mindful of their pain, touching it and moving it away, like Trungpa Rinpoche would say. Or you can be creative and discover your own pathway forward. I will say that therapy in general, we're at a place where we're beginning to hit what Freud's dream was, which is a biologically rooted psychotherapy. But we also are at a place where there's so much creativity and so much innovation needed and so much human suffering that is unaddressed or unmet by the decency of a present, caring human heart, that I would just challenge you to be innovative and then not to pretend that your ideas aren't worth sharing. Write them down, do a case study, share them with others. I've learned things today from you all, and I've been doing pain management actively multiple times, 30% of my caseload for 7 years. So, and some of you may or may not have had that experience that I've had, but I still learned from you today. So keep that active stance. Our field needs you. And if you're looking at what pain neuroscience education includes, here are some of the core topics with talking points. There are 10 of them. If I gave you all 10 points, it would make your brains hurt, and I've already made your brains hurt enough. They're in the slides. I would suggest looking them up at your leisure and thinking about how they might relate to a case. If you have a case that comes in that has chronic pain, and maybe it's not their focus of treatment, challenge yourself to make it not off the list. Pull up this slide, look at what might help them, you know? And that link down there is also a good one. The color is bad, but the link is good. So building pain acceptance has to do with, is relational fundamentally. And I'll just, this might be a really nice ending question I'll just have, and then I'll leave open for any questions that you all have left, is how might you have a difficult discussion with a patient about this idea of the difference between hurting and harming? What metaphor might resonate with you? Do you have any fears about it? How might you bring it up? I try to keep the easy questions for an 8:30 at night.
Michael, are you referencing how certain things we could do can be hurtful but growth oriented versus pushing self too far and being ultimately harmful?
Absolutely.
I was thinking of one of the last slides with the function and the pain crossover. Mm-hmm. And a patient I had that when he was able to stay in meaning, function would improve, but it's so hard to stay in meaning and to keep that orientation forefront.
Yes. And
he would lose it. It would backtrack, and the pain would then increase, functionality would decrease. And it was just a constant, when he was feeling functional, could he lean toward feeling more emotion, more effort to try things that he wasn't able to do for so long when he was laying on his back. And then once again, the crossover and keeping that meaning forefront.
Thank you for that. That's beautiful, actually. Thank you for that. Yeah, it's a really good, and I think, when you look at this slide, you see these kind of little divots, and they look so simple. When you're in one of those downturns, it does not feel simple in the slightest, And it doesn't feel simple to me as a clinician. I can sometimes feel like I've joined my patient right there in their seat next to them going, oh shit, maybe they're not going to get better. Maybe this is the one case that's going to prove that I can't do this or it's not possible. And I have to work with my own existential needs in that moment. you know? And sometimes just keep that endurance of, like one of my therapy instructors would just say, keep your seat, just keep your seat. You don't believe it yet, but just keep your seat, you know? And I have a feeling that your capacity to keep him steady in that meeting helped him keep coming back. So it became an anchor and a more of a progress. You didn't mention that he gained more capacity, but did his tolerance for meaning grow and his capacity for pain experience grow, or did it not grow?
It did grow, but then he would thrust himself too far forward and the flare-ups, and it was just immensely complex, which was my reference to the YouTube video with the drawings.
That's beautiful. And actually, that's one of the big teaching things that I'll do with the patient that's the pacing thing. So if you don't do enough, you'll end up flat on your back from the pain and not move. But if you do too much, what ends up people do is they will end up getting flat on their back and then getting pain avoidant. And so I'll start to teach people to find their window of tolerance in the same way we might for trauma, the window of tolerance of exertion versus rest. So for some patients, it's as simple as, I want to make a really nice souffle. It's a 90-minute meal to make. I love making that souffle. You know, you got a guy who's a great chef, but I can't stand that long. So we bring in a timer, a cook timer, and turn it on for 10 minutes. And every 10 minutes, he has to go park his butt in a chair somewhere and take a rest. You know, but that also works with that meaning too, and learning how to not go past our threshold, like you would in trauma, and to freeze past the pain threshold as you get into a kind of a pain flare up. And that's a really powerful insight. Thank you for sharing that. I'm really grateful. Anybody else have a thought or two as we're wrapping up here?
Yeah, pain is not a straight line necessarily experientially. That too should get divots and twists. And
yes, it should. That's good. So I'll just challenge you as you go forward to think about how you talk about some of these things. And the hurt versus harm is, if I put my hand on the stove, right, my hand will be burned and I should remove it, right? Did anybody ever see Dune? Man, I'm flying my geek flag high tonight. So in Dune, the main prince was put through this test where he had someone put a stick that would kill him up to his neck, and he put his hand into a box, and the box made him feel like his hand was burning off, but it wasn't. And the test was, could he be mindfully present with that pain and not flinch? And in this particular science fiction, if he flinched, they would have killed him. So that's an added bonus, right? But that ability to know that they were triggering his brain to produce pain, but his hand wasn't really getting burned. That's often that ability, you know, that we're working with, you know. And it's also that mindful ability to know that I had a really deep realization at one point that gave me a lot of peace for a while. It sounds trite when I say it now, that all of my emotions were just a sensation in my body. And what that didn't mean was that I needed to ignore them. But what it did mean was that they weren't the truth of who I was, you know. And I suddenly had this blissful distance that allowed me to have a tender compassion to them in ways that I never had. And pain can oftentimes have that too, you know. It's a sensation in the body, but that witnessing presence is so much bigger and so much deeper. Or maybe said in a less trite manner, you know, you're the sky, you're not the cloud. And I don't care how damn intense the hurricane is, it isn't going to break the sky. You know, and to give people that ability to lean into that powerful bit of their own presence that holds that deep space. Thank you all. As always, as Joshua will remember, I always add slides at the end that I don't expect to get to. These are things that are just, you know, there for fun. These are like how you might construct a system if I had my wish list and $1 billion. And these are some other just tools in that way. And this kind of connects up the different levels of pain in the brainstem with different interventions, just so you know that it's there. There's quite a few tools that I shared. Many of them are patient handouts that you can use. Just encourage you to play with them, explore them, read a few things. Most of them have some language on the back and some language that's patient-centered. So you could just read the language to somebody. You don't have to, you know, remember it all or know what the slide means. I'm grateful to be in this learning space with you all. Thanks for being here. It's wonderful to share this and to grow.
Thank you so much. It's great.